Hello, welcome to our program, More About MS, Coming of Age with Multiple Sclerosis. Before we begin, I'd like to go over just a few introductory remarks. We are excited that this program is occurring during World MS Day this year. By holding this program, we are helping to share stories, raise awareness, and advocate for everyone living with MS. First, we'd like to thank Biogen, Bristol Myers Squibb, EMD Serono, Genentech, Mallinckrodt Pharmaceuticals, Novartis, and Sanofi Genzyme for their generous support of this program. Before we move on, I'd like to point out a few features on our program platform. On the top left-hand corner, you will see buttons that will allow you to access informational materials that we have for the program. We encourage you to visit the exhibit hall, where you'll be able to access important information provided by our exhibitors for people living with MS. On the bottom left-hand corner, you will find buttons that will allow you to interact with the speakers in the slide presentations. And we encourage you to ask questions using the Ask the Question button to submit questions to the speakers. We have received many questions already during the registration process, and we are going to do our best to answer as many of those questions as possible, those questions and those that are submitted during this program. We will be playing videos throughout the program. Videos will play in the small screen in the upper right-hand corner. To optimize your viewing experience, we encourage you to click on the square icon to view the videos in full screen. Lastly, we encourage you to follow us and use the hashtag #MoreAboutMS to share your experience during this program. Again, thank you for joining us today, and let's begin.
Welcome to More About MS, Coming of Age with Multiple Sclerosis. We are honored that you have joined this program designed specifically for people living with MS and their care team. The Consortium of Multiple Sclerosis Centers and Catamount Medical Education have worked closely with the faculty for this program to develop an educational and engaging experience. Today, you will hear from Program Chair Dr. Randall Shapiro and the esteemed faculty Dr. Gary Birnbaum, Dr. Peter Wade, and Ms. Patricia Bobrick. Let's get started.
Well, good morning, folks. I'm Randy Shapiro, and I'd like to welcome you to the Consortium of Multiple Sclerosis Center's second annual patient program, More About Multiple Sclerosis, Coming of Age with Multiple Sclerosis. The CMSC is the preeminent organization for professionals who are interested in multiple sclerosis. As an organization, it is over 30 years old. This is our second program for patients, but the organization is over 30 years old. And the organization provides resources for clinicians and researchers to complement the National Multiple Sclerosis Society, the Multiple Sclerosis Association of America, the Multiple Sclerosis Foundation, Can Do Multiple Sclerosis, Accelerated Cure Project, the International Organization of Multiple Sclerosis Nurses, United Spinal, and Multiple Sclerosis News and Views, and those make up what we call the MS Coalition. Today, we have assembled a very experienced faculty from around the country. They're all senior in their fields to help educate us about multiple sclerosis on this MS World Day. But before we begin, we are a nation in turmoil, and I'd like to take a moment to express my concern, grief, and fear for my hometown, Minneapolis, which is undergoing some rigorous difficulties at this point. And I'd also like to take a moment to think about all of those who have been affected by COVID-19. And there are over 100,000 deaths that have occurred in the United States from that terrible virus. So for just a moment, I'd like to stop and pause and think about them. Obviously, a moment is not enough, but we will continue on. This program would not have been possible without the generosity of our supporters. As we move through the agenda, we'll be taking a moment to recognize each of our supporting companies. Before I begin with my talk, let's take a moment to recognize our first supporter.
The Consortium of Multiple Sclerosis Centers and Catamount Medical Education would like to thank Biogen for their generous support of this program. This support has made it possible for us to provide this valuable educational program for people living with MS and their care partners.
Well, let me welcome you again. I'm going to start with my talk about aging and multiple sclerosis. I have some disclosures to tell you. You know, when I was younger, in my 40s, let's say, and people came to me and said, what is your expertise in multiple sclerosis? How much experience have you had, you young fellow? I used to be able to say to them, you know, I'm in my 40s and I've had 40 years experience with multiple sclerosis. And they would look at me sort of strangely. Well, it didn't happen often, but when it happened, I could say that because my mother had multiple sclerosis. She got it when I was born, and so I lived with that disease as a child throughout my childhood and adolescent life. So I'm an expert in multiple sclerosis as from firsthand, and then I became a neurologist, and that's been my life work for all of these years. So that gives me some credibility, I think. But you know what happened over those years? I got old. And when I got old, I became an expert in what? Aging. And so I come to you as an expert in multiple sclerosis and an expert in aging, not because I really want to be, but because that's what happened. So I want to tell you something. I'm going to switch back to this. I want to tell you something about aging. You know, it's good to get old. And when I was younger and I lectured about multiple sclerosis in general to newly diagnosed groups, I found that I scared the daylights out of them by telling them everything that could happen to them. You are pretty much aware of the things that can happen in multiple sclerosis already, I suspect, but it can be a very scary disease. Well, let me tell you something. Aging can be just as scary. And all of us that are getting old understand the issues that have come with that. And we don't like them, but in fact, aging is good. Why is it good? Well, you know, when you're a parent, you've got all the responsibilities and duties to raise your children and to make your family work itself into a good place. And then you become a grandparent and you lose those responsibilities and you can simply enjoy the kids. You can simply enjoy them. My slides started moving by themselves here. Let me get back. Hello. What's going on? There we go. So you become a grandparent and you get experience, and that's good. So aging gives you experience, and with experience you get wisdom. So you go from being old to getting smarter as you get older, and you age gracefully. You know, when you get older, your conversations turn to medical things. All of our neighbors are in our retirement community here in Arizona. We talk about lots of things, mainly health issues. And so it's appropriate for us older folks to explain this to you younger folks. You know, if you have an opportunity, you should go to the internet and look up Fritz Coleman, C-O-L-E-M-A-N, Fritz Coleman. He's a weatherman in Los Angeles, and he's a comedian, and he has a great stand-up routine on aging. I just love the routine. You should do that. You'll be amused. But Fritz talks about how your body wants to change as you get older, how your chin decides it wants to become a stomach and it sags down to become a stomach, how your legs begin to swell and decide they want to become ankles and your ankles begin to swell. He talks about the male having to go to the urologist on a routine basis, and he talks about that as a rite of passage. He calls it a bat mitzvah. You can tell you're old, I can tell you this personally, because you get your AARP card, and that lets you know. But the fact is that it's inevitable. So I want you to stay positive, I want you to stay mobile, I want you to relax, and I want you to enjoy what we're doing today. This slide says, big breaths. Well, they used to be. You know, aging is normal. And I want to talk a little bit about normal aging. You know, we are born, we age, we die. That's new material to you. But yesterday I heard a wonderful talk, an academic talk from the consortium of MS Center's annual meeting by a Dr. Jennifer Graves, who is a neurologist in San Diego. and she talked very academically about aging. And she talked about biologic age versus chronologic age, and about how we have a biologic age that is determined by biology, but we have a chronological age that's determined by birth and what have you. And we can alter our biological age by doing things to help ourselves potentially. And then a lot of this has to do with our genes and how the genes now are being looked at as we age and how they may determine the course of multiple sclerosis. It was quite a good scientific talk, but it taught me what I already knew, that you need to pick your parents carefully, because so much of what goes on is in the genes. Now I want you to look at this slide, and I want you to pick out where you are on this continuum. Whether you're male or female doesn't make much difference. You can change the anatomy and it looks the same. You know, on the right, you see the infant. We all can relate to that. We remember when our kids were infants. And then the toddler occurs, and then the young adolescent, and then there's us. We all see ourselves as the middle picture. We don't change from that, but reality, we do change. I begin to look more like the left, and then if we wait long enough, unfortunately, we all kind of end up like on the right. This is the natural aging process. Gravity has lowered my chest, my stomach, my butt, but why hasn't it lowered my cholesterol? Well, I want to tell you some facts of life, and these are things I've learned from experience. When you're 40 and going to be 50, there's no difference. You don't feel any different at 50 than you did at 40. We all can probably relate to that. And when you go from 50 to 60, you don't feel any different from being 50 to 60. But when you go from 60 to 70, something happens. There's a change, and you feel it throughout your body. And I can tell you firsthand that when you go from 70 to 80, lots of changes begin to occur. That's the facts of life. So we're going to talk a bit about normal aging in somebody who doesn't have MS or who has MS. We all are going to go through normal aging. It has not to do with multiple sclerosis. When we get older, we notice that there is a decrease in oil and elasticity in the skin. Our nails become tougher. Our hair begins to thin. And our skin looks like this. You bump it on anything and you get red marks. Unavoidable as you get older, as we lose the elasticity in the skin. As we get older yet, our bones become porous. We lose calcium in the bones. We lose calcium in the bones, but the calcium seems to have to find itself somewhere, so it goes into the joints. And instead of osteoporosis and decreased calcium in the bones, or in addition to that, we get bony joints, and we call that osteoarthritis. And as we lose the calcium in the bones, of course, our vertebrae shrink and we lose height. We get shorter. So here's a slide of a healthy bone on the left, an osteoporotic bone on the right. And I take your attention to where it says compact bone, and you notice the thickness is different on the left than it is on the right. I apologize that I don't have a pointer to point this out, but the compact bone is thicker on the left than it is on the right. And you can see the difference in the spongy bone. And when that occurs, those bones become more fragile and they begin to fracture and shrink. And our body habitus changes from the 35-year-old on the left to the more 55-year-old with the pot belly on the right, and the 65-year-old as our vertebrae compress. And I went from being 6'4" to 5'8". No, not really, but I did go from being 5'9" to 5'7.5". Dang it, anyway. I always wanted to be taller. But as our bones shrink, our belt buckle moves up. So you can tell somebody who's old age by the fact that their belts are up around their chin, as opposed to the youth whose belt buckles are around their knees half the time, I think. Oh my, it's tough getting old. Normal aging. What happens to the muscles as we get older? Well, you know that we get a decreased muscle mass as we get older. And so we feel weaker as we get older, the decreased muscle mass that occurs. And with that decreased muscle mass, we get weakness going on. And our heart and lungs become less efficient. There's a stiffness that occurs to the blood vessels. And with that stiffness, we get an increased blood pressure. and a decreased lung capacity. So things change in our heart and lungs, and they change in our face as well. The youthful face on the left with no wrinkles. That's what we all ascribe to. And then as you move to the increasing age, you can see the wrinkles occurring. I can see them in me as I'm looking at you. These wrinkles occur. You can just look at Bridget Bardot here on the left and the way she is today. What a change. She was my heartthrob when I was younger, and look what happened to her. It happens to all of us as we get older. So our digestion changes as well. Supposedly, we get a decreased appetite. Yeah, right. That hasn't happened in my family. We don't have a decreased appetite, but we do all have some problems with constipation as we get older, almost all of us. And we have problems with gastric reflux. So we get gastric irritation as we get older. So the bladder also becomes weak. And when you're a male, you have prostatic problems. When you're a female, you may have a fallen bladder type of problem. So the bladder becomes an issue, and we start focusing on that as we naturally get older. Not with MS, just naturally getting older. And of course, you know about the sexual function issues. You just have to watch television or listen to the radio for a moment, and you know that as you get older, sexuality has to change and it has to become a different issue for us. Normal aging, our eyes change. We start losing our near vision, and we have to wear all those readers, and we can maybe see further. That's called presbyopia. But the vision blurs because the cataracts, the lenses begin to become impaired, and our night vision decreases. And what'd you say? Say again? That's my favorite phrase these days. Say again? Because our hearing decreases. And tinnitus. When I was raised, it was tinnitus. Somewhere along the line it became tinnitus. But tinnitus, ringing in the ears, becomes prominent in virtually all of us as we age. And you know what? Our brains naturally shrink with aging. We call that atrophy. We're going to come back to that. But they actually shrink about 0.5% a year. Brains normally shrink, and we have problems sometimes with planning, foresight, and judgment simply by aging. So aging is tough. However, it beats the next best thing, which is not aging. Now, I'd like to show you this slide, which you've all seen, and I see it projecting in a funny way as they reformatted the slides. But let me talk you through this just for a moment, because it's so common to see this slide. And I want to call your attention to the upper left-hand words that say natural history of multiple sclerosis. And what you see on the bottom are arrows, and those are MRI attacks of the disease. And so what we know is that the disease occurs before we know it. We see an MRI sometimes activity, and the person has not had a symptom. We call that preclinical. And then you see in the middle, the orange line gets a blip. That's the first attack of multiple sclerosis. So we've labeled that then as a clinically isolated syndrome. And when you get that second attack, we know that it's multiple sclerosis. So we call that relapsing remitting multiple sclerosis. And 80 to 85% of those with MS begin their course of the disease with this type of approach. And over half of them, if left untreated, will then slowly start getting worse, and we change the name to secondary progressive multiple sclerosis. And you notice that the arrows, the lines are all in an upward trend, except for that green one, which is the shrinkage of the brain. Everything else is in an upward trend. Then this is then labeled as the natural history of multiple sclerosis. But it's not. It's not. And that's why I put this slide up here, because I've seen this slide already in the academic talks, and it's not the natural history of multiple sclerosis. It is the natural history of multiple sclerosis in one patient, the one that's depicted here. So it's really important to understand that every single person who has multiple sclerosis is different. And that while these lines go up, they don't keep going up, because you don't die from MS, you die with MS. So this is a little bit misleading. And so we as clinicians recognize that things are different these days with the medications and with the natural history as we've learned about it. And so now we talk about relapsing remitting and secondary progressive as being active or not active, because sometimes it's very stable, even though we call it secondary progressive. It can be very, very stable. So I'm going to give you some of my opinions on aging with multiple sclerosis. These are generalities, and these are my opinions. I can guarantee you that somebody will object to my opinions. But I'm the expert because I've been around for all of these years, and I've seen it with my own eyes. I can tell you firsthand that MS tends to plateau as a disease in most people in their 60s. Most people in their 60s. People will tell me, oh, no, it doesn't. It keeps on going and going and going. But I can tell you that for a fact that clinically, MS tends to plateau as a disease in most people in their 60s. Now, that's not true of everyone. There are many exceptions, but that's a generality. So, unfortunately, the body continues to age. The body ages, and with age, you don't do physically as well, MS or no MS. So, people may not do as well as they age, but it may not be due to their MS. It may be due to the fact that they have less brain reserve because of their MS in the past, and now they're losing brain because of aging, and things don't work as well. This has important clinical meaning, and when we think about treatment, which we'll talk about in a few minutes, in a moment. So there are many, many variables that go on. I want to give you some facts to think about with aging. The life expectancy for people with multiple sclerosis is slightly diminished compared to the average population, but not a lot. Not a lot. And what do you think? What do we do with disease-modifying treatments in this age group? We're going to talk about that. If in fact the disease is somewhat stabilizing, do we have to stay on these expensive disease-modifying treatments? 72% of the older folks are females, and 25% are widowed. So it's an aging group of people. So people die with MS, not from it. That's something important to understand. So we're going to talk about what happens now as you age with MS. So we get a loss of muscle mass with MS or without MS. We are going to lose some muscle mass. With MS or without MS, we're going to see osteoporosis. With MS or without MS, we're going to have problems with pain. With MS or without MS, our nervous system is going to age. With MS or without MS, we're going to have memory issues. With MS or without MS, we're going to have bowel and bladder issues. With MS or without MS, we're going to have bladder or balance problems occurring. With MS or without MS, we're going to have visual problems occurring. With MS or without MS, we're going to have fatigue problems occurring. With MS or without MS, we're going to have sleep disturbances. Remember, I started this talk with saying getting old is good? I'll still say that, but we're going to have to deal with these problems with MS or without MS. And on top of that, our immune system is going to age as well, with MS or without MS. So what can we do to improve the quality of life in MS while aging, or improve the quality of life while simply aging? Sometimes it works both ways. Let's see. Let's look at the muscle. The effect of aging in the muscle is that we get atrophy. Those muscles begin to shrink, and they can shrink because we're not using them, so they get what we call disuse atrophy. Or they may shrink because of the effects of MS. If the nerve supply in the spinal cord and brain that's affecting the muscle is not working right, that muscle will shrink. It will atrophy. Here's a picture of what I mean by atrophy. The left side with the black sock is a normal leg. You can see the atrophied smaller leg in the right side with the white sock. That's atrophy. That's going to occur. It occurs in almost all of us with MS or without, but obviously it occurs more in MS. So what can we do to keep that from happening as severely as it might happen? There are things we can do to take care of ourselves. First of all, we have to eat right and give the right nutrients to supply function to those muscles. It's important to do that. And it's important to exercise. So that's going to bring up a concept that I know Patty Bobrick is going to talk about, but I'm going to just mention over and over again, exercise is essential for a higher quality of life. So if you don't use this muscle, you will lose this muscle. On the other hand, if you exercise a muscle that is not got the right nerve supply, it will fatigue. So it's important to understand how to exercise. So that's where the physical therapist comes in to teach you how to exercise so that you can maintain the muscle strength that you have and maybe potentially gain some muscle strength if it's possible. So there's something to do for loss of muscle. Let's look at those bones. I already told you that osteoporosis is a problem. The bone density diminishes with MS or certainly even without MS. Fractures begin to occur. They may be occurring in your vertebrae, in your bones, or they may occur in your arms and legs. So pain gets associated with this. So we get bone density diminishing, fractures occurring, pain occurring. What can we do for this? Well, first of all, we need to test that bone density to see how significant it is. Then we want to put you on some exercises to try to keep that bone density from getting worse, because we know that exercise can preserve bone. And so there are testing machines that will help you look for that. I'll show you a picture of that in a moment. But then we may want to add, depending on your doctor and the test results, calcium and vitamin D to keep the osteoporosis to a minimum. So testing that bone density becomes important for a large number of people as they age. And we see pain with MS and without MS. So there are many causes of pain. There are neurologic causes of pain, which you see with MS. Over half the people with multiple sclerosis have burning, irritative type of pain. But you may be also getting rheumatologic causes of pain from the osteoarthritis that's occurring in your joints and in your bones. And then there are obviously many other causes of pain. So what do we do for the pain? Well, first of all, we have to find the cause of it. We want to treat the root cause. And then we use those pain medicines judiciously. We don't like opiates in these circumstances because this is chronic pain. So there are neuropathic medications. There are anti-inflammatory medications, depending on what the source of the pain is. So we want to get on the right medicine for the right symptom at the right time. That nervous system is going to age. Things just simply slow down. And when they slow down, part of the reason they slow down is that we're shrinking our nervous system. We're losing our brain and spinal cord as we age. And obviously we lose it because of multiple sclerosis as well. We call that atrophy. So here you see on the left actual scan of a healthy person and then a person with MS. And look at the schematic. It's a little easier to look at. In the normal person, we see spinal fluid. Those are the slits. And you see on the severe MS that there's more spinal fluid there because we've lost brain substance. We've lost tissue. And that gives us an increase in fluid. We call that atrophy. We don't like atrophy. We want to preserve our brain. With MS, there's a significantly higher loss of brain than there is with aging, but we lose it with aging as well. So what can we do? Well, first of all, when you're younger and have active disease, or even if you're older and have active disease, you need to be on a disease-modifying treatment. And aging certainly beats the next best thing, which is worse than that. But you need to stay active. You need to stay active. I want to talk a little bit about cognition, because that's what happens when you lose that muscle mass. We have decreasing cognition. And what happens with your memory, planning, foresight, and judgment? MS is not Alzheimer's, and it's important to differentiate between that. In Alzheimer's, we get what we neurologists call a cortical dementia. We lose our ability to think across the board. In MS, we get what we call a subcortical dementia. And our thinking is more of a recognition problem. It's stored there, it's getting it out. So sometimes it's word finding, sometimes it's a loss of immediate memory here and there, but it's a different kind of problem. What can we do to deal with cognition? Well, again, when I talk to people about treatment of cognition, I say when the disease is active, it's really important to stay on those disease-modifying treatments because we can't get back what we lose. We need to try to maintain our function. So that's really important. But as we get older, I learned something. You know, over 35 years ago, I started a center for progressive MS in Minneapolis. It was called the Fairview Multiple Sclerosis Achievement Center. And we had over 200 people with significant MS come once or twice a week for the whole day for maintenance rehabilitation, to keep them functioning in the community. They were not in nursing homes, but they had severe disease. Almost all of them were in wheelchairs. So that we had this severe disease. And what can we do? The fact of the matter is that people with MS stop going to movies, they stop going to restaurants, they stop going to church, and that's an issue for them. And so we need to figure out what we're going to do to stimulate them. And these people went to the Achievement Center and they got smarter. And why did they get smarter? They got smarter because people were talking to them and asking them questions. And so I learned something, that the brain is not a muscle, but if you don't use it, you will lose it. So we want to exercise that brain. We want to utilize all the tricks that are possible to keep our cognition intact. We know that the bowel and bladder is a problem with MS and without MS. There's incontinence in each. And then mobility problems add to that incontinence. And so what can we do? Well, we need to make the correct diagnosis. Is it a small bladder, a large bladder, a conflicting bladder, and develop a treatment strategy based on that. Same with the bowel, and make appropriate accommodations. You know, nurses are important because they can choose your catheter size. So balance becomes an issue as you get older. And I want you to understand that what goes into balance comes from your eyes, it comes from your ears, it comes from your muscles, it comes from the nerves and sensation in your legs, it comes from the back part of your brain, the cerebellum, and falls become prominent. So when we develop problems with balance, we call it ataxia, and we have to find out why. Why do you have that? So when you look at our actions, you make the proper diagnosis of what's wrong, and you develop an appropriate treatment plan based on that. And that means fall management. Exercise to stimulate those parts that aren't working as well. We use all the tools that we possibly can to keep our balance. Our eyes have a problem with atrophy and weakness in our eyes. We can see that optic atrophy, but also we get cataracts. There are other eye issues such as double vision and other types of problems that occur in the eye with aging. So what do? Well, that's dependent on the problem. Get appropriate eye care. Fatigue is a problem in all people. It's the single most common and the single most disabling symptom in multiple sclerosis. There are 5 different kinds of fatigue in multiple sclerosis. Normal fatigue, lassitude, the overwhelming tiredness, which is the predominant fatigue that we see in multiple sclerosis. Deconditioning fatigue, the fatigue of depression, the fatigue that occurs with medications and things of that nature. So we need to distinguish the fatigue and treat the underlying problem. You can change the things you can change. We see sleep disturbances. Some of them occur because of the actual MS. Some of them occur because of the medications you're taking, or your bladder, or there's secondary sleep disturbances. So you need to get a sleep study, and you need to be reviewing your medications and develop a treatment plan dependent on the problem. The immune system ages as well. That can be bad, but it's potentially good. How does that work? Well, we have a word that we call immunosenescence, the aging of the immune system. And in the normal person, that aging immune system is not a good thing, because then we become more likely to get the COVID-19 virus or other viruses of various sorts. But if the immune system is overactive and causing multiple sclerosis, maybe that aging immune system will make it less active, and you won't need to take, and the MS will become less active. So that leads us to maybe you can stop those disease-modifying treatments. That you have to discuss with your doctor, because it may be possible. We have to deal with the COVID-19 these days as well. And so what are we going to do? Well, keep our nutrition up, keep exercising, because that's good for the immune system as well. And then you consider the path of the disease and its treatment. Make sure you're vaccinated to keep yourself from getting some of these diseases that occur as you age. And then make DMT decisions in the face of this virus with your clinician, because we need to be intelligent. Clearly, the COVID-19 is a negative for age. So we need to socially distance, wash hands, wear masks, stay social via technology, stay mobile. We need to deal with the managed care as we age as well. What's the goal of managed care? Is it health or is it wealth? And that's a good question. And for physicians, we're dealing with managed care, and that removes the decisions from us because we're always dealing with the insurance companies, which raise overhead and decrease reimbursement and cause a problem with our time with patients. I'm sorry, we're bombarded with aging boomers. Come back in about 20 years. My belly is a vital part of my 401k plan. I have to live off this fat when I retire. So there are a lot of people out there to help with aging. There's transportation help. There's assistive devices help. There's assisted living help. There's adult daycares. There are nursing homes. There are end-of-life issues. We have to deal with all of these. Remember, getting old is actually good. Even though we have all of these, it beats the alternative, but we do need to pay attention to all of these issues. I end with this, the cat in the hat on aging. And even though I think getting old is good, I cannot see, I cannot pee. I cannot chew, I cannot screw. Oh my God, what can I do? My memory shrinks, my hearing stinks, no sense of smell, I look like hell. My mood is bad, can you tell? My body's drooping, have trouble pooping. The golden years have come at last. The golden years can kiss my ass. Well, I'd like to thank you for getting old with me. And so, before we move on, let's recognize our next supporter.
The Consortium of Multiple Sclerosis Centers and Catamount Medical Education would like to thank Bristol-Myers Squibb for their generous support of this program. This support has made it possible for us to provide this valuable educational program for people living with MS and their care partners.
Thank you again for joining us today. Since this is a patient program, we value your input and would like to hear from you. And we're going to do that through a fun activity. In a moment, a slide will appear, and the slide is going to have a question or directive asking you to give us one word that comes to mind. For example, if someone asked me to use one word to describe the weather in Connecticut, where I am today, I would say fabulous. There will be 3 rounds, and the important thing here is only to type in one word. That's right, only one word. Okay, here we go. Use one word to describe your motto for living with MS. Who is your strongest advocate? Where do you get your MS information? Okay, while we continue with the rest of our program, behind the scenes, our crew will be creating word clouds using all the words you submitted. And at the end, Dr. Shapiro is going to show us what these word clouds look like. Now, before we move on to Dr. Birnbaum's talk, let's recognize our next supporter.
The Consortium of Multiple Sclerosis Centers and Catamount Medical Education would like to thank EMD Serono for their generous support of this program. This support has made it possible for us to provide this valuable educational program for people living with MS and their care partners.
Hi, this is Dr. Gary Birnbaum, and I'll be talking with you about the very latest in MS research. I'll be presenting a lot of information, and I only have 1/2 hour to do so. The good news is that you'll be able to go over my slides in the coming year, and hopefully that'll be able to make it more understandable for you, but I'll certainly try my best. This is an outline of my presentation. I'll be talking about new concepts on the pathology of MS, some new ideas in the diagnosis and treatment of MS, and some very exciting new information on potential evolving treatments for the disease. So first, let me talk about pregnancy and MS. We all know that MS disease activity is reduced during pregnancy. The reasons for this are not known, but there was a recent paper that could provide some very interesting information in this regard. This is the paper here. At the bottom of the title, you see in blue the particular website that will allow you to have more access to this particular paper. So exactly what did these scientists do? Well, they took blood from women with MS who were pregnant, and they had a control group of pregnant women without MS. They isolated immune cells called T cells from these samples of blood, and they grew them in tissue culture to make T cell clones. They were able to identify specific clones on the basis of very specific proteins on the cell surface of the cell. These were proteins called T cell receptors, which are essential for T cells to become stimulated. These particular receptors interact with small fragments, if you will, of proteins. And with this interaction, these cells become stimulated and begin to multiply. So this is a schematic of their experimental protocol. They took T cells in the beginning of pregnancy, followed patients during pregnancy and after the birth of their child. And what they found was, very interestingly, that particular clones of T cells were reduced in women in the course of their pregnancy. And these clones were not reduced in patients who did not have MS. They were private clones, and by that I mean that each individual had their own particular set of clones that did not seem to overlap with any of the clones from other individuals. As the numbers of these particular T cell clones decreased, MS disease activity decreased. And then something very surprising happened. After these individuals gave birth to their children, the numbers of these clones dramatically increased, even higher than they were originally. And this was associated with an increase in disease activity. So then the scientists asked the question, well, what could be stimulating these particular populations of cells to respond? And they studied a bunch of different antigens, a bunch of different proteins that have been implicated in the cause of MS. They looked at myelin proteins, they looked at virus proteins, Epstein-Barr virus proteins. None of the clones responded. So what does this all mean? Well, these are very important observations because they raise significant questions. What are these clones responding to? Are they different for different individuals? Is MS really a disease or is it a syndrome? Do people with MS all respond to the same antigens? Why are the clones suppressed during pregnancy? Is this hormonal? Is this another function of the immune system? And most importantly, what stimulates these clones to expand after delivery in association with an increase in disease activity? So very important observations. As often happens, there are more questions raised than answered, but I think this is a very important series of observations. Now we know that myelin destruction is the essential pathogenic process in MS, and we know that immune cells are very important in destroying myelin. But of course, in addition to myelin being destroyed, nerve cells become injured. We have other cells that become injured. The oligodendrocytes that make myelin are destroyed. In addition, there are new data to suggest that other than the immune system, other cells are involved in tissue destruction. And this has very important therapeutic implications. All of our disease-modifying therapies are directed against the immune system. How are we going to address these other cells that are involved in the pathogenic process? So this was an interesting paper I was able to find on the role of astrocytes in promoting brain inflammation. Now, what are astrocytes? Well, they're an essential part of the central nervous system. They are glue cells that hold the central nervous system together. But in addition, they nourish nerve cells, they maintain the inner layers of blood vessels, they stabilize the metabolism of the environment surrounding nerve cells and oligodendrocytes and allow them to function most efficiently. They also are greatly affected by both external and internal processes. For example, the gut microbiome, I'll be talking about that in a few minutes, has a role to play in affecting astrocyte function. Your environment has something to do. If you're a smoker, it most definitely affects astrocytes. Substances released by immune cells, so-called cytokines, affect astrocytes, as well as other cells in the brain, such as microglia. So the astrocytes are part of a very complex system of interactions that may be having an important role. So what did the scientists do? They examined astrocytes in autopsy tissues from persons with MS, and then they looked at a mouse model of MS called experimental autoimmune encephalomyelitis, fortunately abbreviated EAE. In particular, they studied levels of certain genes, and the two genes that they studied were called MAFG and NRF2. Now, what do these genes do? Well, the MAFG gene suppresses genes that protect the brain. So having too much MAFG activity actually increases inflammation and decreases the protective effects of other cells. The NRF2 gene has the opposite effect. It protects against oxidation and toxicity as well as inflammation. So the MAFG gene is obviously one that we do not like. The NRF2 gene is one that indeed we do like. So what did the scientists find? Well, they found that levels of the anti gene, the MAFG gene, the bad gene, were increased in astrocytes from persons with MS and in mice with EAE. And as a result, these animals had increasing inflammation. In contrast, the protective gene, NRF2, was reduced in astrocytes from persons with MS compared to controls, and was reduced in comparison to mice that did not have EAE. So this is a schematic. I realize it's somewhat hard to see, but the higher lines here show the severity of EAE in these mice. If mice had higher levels of MAFG, their disease was worse, as you see on the left. If they had lower levels of NRF2, in red, you see that their disease was also worse. Again, this is the slide difficult to read. I apologize for that. This compares MS tissues with control tissues, and as you will see if you can magnify this at your leisure, the MAFG gene was decreased in controls and increased in the bottom series of boxes in MS patients. The NRF2 gene was at high concentrations in control tissues and was decreased in astrocytes from persons that have MS. So what do these findings mean? Well, they now implicate another major cell type within the central nervous system as a potential pathogenic cell in terms of the MS disease process. And what we now need to figure out is what really triggers these astrocytes to become potentially pathogenic, because then we'll have to design a whole new series of disease-modifying therapies addressing not just the immune system, but a population of cells that may contribute to underlying tissue destruction. So this is a very important observation in terms of what may be necessary to really fully treat MS. New concepts in the diagnosis and treatment of MS, I'll be talking about two things here. One is neurofilament light chains and the gut microbiome. Now, what are neurofilament light chains? Well, these are chains of proteins that are found inside nerve cells or neurons. And when nerve cells are injured, neurofilament light chains are released into both the spinal fluid and the blood. And if you measure levels of neurofilament light chains in spinal fluid and blood, they correlate. So high levels in the spinal fluid are found with increased levels in the blood. And they increase with any damage to neurons. So they're not MS disease specific at all. Anything that injures a nerve cell is going to result in an increase in neurofilament light chains. Now, there are a lot of data that have shown that these NFL increase in the blood and spinal fluid during times of active MS. And they increase oftentimes in the absence of clinical relapses, and even without any changes on central nervous system MRI. So they're very sensitive to underlying nerve cell damage. And measuring them may actually provide a clue as to the origin of MS or the triggering process for the disease. And this was a potentially very important paper that I found in terms of measuring serum neurofilament light chains even before the diagnosis of MS was made. And again, there is the particular website underneath that will allow you access to this particular paper. So what was done? Well, if you join the American military, they draw blood on you and they store it. And as you continue to serve in the military, they take repeated samples of your blood and store it for the long term. And what these researchers did was they measured neurofilament light chains in blood samples from persons who entered the military but didn't have MS at the time of diagnosis. So then they went back after the diagnosis of MS was made, and they sampled neurofilament light chain levels in these individuals and compared them to matched individuals who did not have the disease. And what they found was amazing. Neurofilament light chain levels were elevated up to 6 years before the time of diagnosis. As when examined blood levels nearer to the time of diagnosis, NFL levels increased even more. So these are some of the data from the paper. On the left, you see the levels of neurofilament light chains in persons with MS 1 year before diagnosis compared to controls. And then at the time of diagnosis, you see there's a broad scattering of concentrations. On the right, you see neurofilament light chain levels 6 years before diagnosis. Again, a broad spread, but generally an increase compared to controls on the right side of the diagram. And 1 year before diagnosis, you see even higher levels of neurofilament light chains compared to controls. So what does all this mean? Well, it means that low-grade smoldering tissue injury may be occurring years before the diagnosis of MS is made, years before neurologic symptoms occur. And by monitoring neurofilament light chain levels in persons at high risk for disease, such as, for example, children or siblings in families with MS, it may be possible to identify the event that actually triggers the disease process. If you see a sudden rise in neurofilament light chains in people that are asymptomatic and that you're following sequentially, you may be able to identify what sets off the disease process. That would be fantastic if we could really identify that. But some cautionary notes. Most participants in this particular study were males, and as we know, MS really is a disease of females. In addition, a rise in neurofilament light chains is very nonspecific. So if you're following younger individuals who, for example, are playing soccer or football, we may see rises in neurofilament light chains, which may not be directly related to what causes the disease. But nevertheless, this is a very powerful tool for trying to really discover what triggers the MS disease process. So let's talk about the gut microbiome, we and our bugs, we and our bacteria. You all know we have more bacteria in our bodies than we have numbers of our own cells, and this is good because bacteria really offer us a lot of protection from our environment. Each organ has its own unique population of bacteria. These are called microbiomes, and there are some beginning data to suggest that the gut microbiome may play a role in MS. We know that many nerves enter the gut, for example, the vagus nerve. These nerves have a major role to play in both motility of the gut and in pain perception. In addition, the gut contains a large population of immune cells, which plays a major role in protecting us from what we eat. It keeps us tolerant to a bunch of substances that we eat and will protect us if we ingest pathogenic organisms. But it also can, of course, increase disease activity if we become allergic to particular ingested substances. So immune cells, we know, can enter the gut, can leave the gut, and can travel to enter the central nervous system, and by doing so, affect brain function. So there have been multiple studies that have tried to figure out what really happens to the gut bacteria in people with MS. And so far, no consistent differences have been found. But it really is a much more complex picture. And this paper really describes phenomena that I think will be very important in terms of understanding the relationship between gut bacteria and MS. This examined gut bacteria in different phenotypes of MS, relapsing MS, primary progressive MS, MS that's active, MS that's being treated with disease-modifying therapies. What was done, stool samples were analyzed from about 120 controls and 98 persons with MS. They were excluded from participating if people were secondary progressive MS, which I think is actually a fault of the study. If they were on disease-modifying therapies other than high-dose interferon, so we're really only looking at one therapeutic population. If patients had bowel disease or if they were treated with steroids or antibiotics. And my slides are not moving. So let me go back one here. What was actually found was that they looked at numbers of bacterial populations, bacterial richness, so to speak, and they found that there were significant differences, not so much in MS patients as a group, but in subgroups of individuals. So for example, they found that there was, I'm going to go back one here. They found that there was decreased bacterial richness, if you will, in people that were on interferon beta. There were decreases in bacterial diversity or bacterial richness in untreated people with relapsing MS who were having an attack in comparison to patients with primary progressive MS and those with benign MS. So what we're now seeing is that there are bacterial differences, not in MS patients as a group, but in particular subtypes of MS at particular times during their illness. If you looked at individual bacteria, the differences were even more striking. If you looked at Bacteroides, which is a subtype of bacteria, they were more prevalent in interferon beta treated individuals. If you looked at Butyricoccus, and it took me half an hour to be able to pronounce this, if you look at Butyricoccus bacteria, they were lower in primary progressive individuals than in untreated MS patients, and Butyricoccus abundance was also lower in interferon beta treated patients compared to benign MS and untreated active are our MS patients. So here is a illustration from that paper showing you bacterial diversity. You can see that the control group is on your left, and you can see significant differences among subtypes of MS. If you look at just the enterotypes, the bacterial richness, if you will, you don't see much of a difference between MS and controls. But if you then identify subgroups of MS patients, progressive patients, inactive patients, treated patients, you see very important differences. So what does this mean? It means that during different phases of your disease, your bacterial population can change. There was an inverse correlation between the self-reported symptoms of an individual and concentrations of Butyrococcus. In other words, the more Butyrococcus bacteria you had, the better your MS. And what could explain this? Well, Butyrococcus is known to produce short-chain fatty acids, which have an anti-inflammatory effect and thus affect the function of the immune system by causing the induction of regulatory cells. So clearly the bacteria in your gut are able to affect the immune system, and the bacterial population changes during the course of disease. Some cautionary notes: there were only 4 individuals with MS who were having an attack. No individuals were examined with secondary progressive MS, and there were no MRI correlates of inflammation. But nevertheless, this information, which is new, showing you changes in bacterial populations with disease activity, provide a very potentially important therapeutic means of intervention. So very exciting now, new and evolving treatments for MS. We know that all current disease-modifying therapies primarily affect the immune system. What's lacking, of course, is a treatment for tissue repair or remyelination. That, at the present time, does not exist. But 2 new papers really suggest that this may be a very viable option. So let's talk about this one paper on Schwann cells, rescuers of central demyelination. This is a paper that talks about the potential for Schwann cells to become therapeutic agents in MS. Now, we know that there are 2 cells that are important in the production of myelin: Schwann cells and oligodendrocytes. And if you look at Schwann cells, they actually have a greater ability to repair and remyelinate than do oligodendrocytes. Schwann cells are found in the peripheral nervous system. They remyelinate our nerves in our arms and our legs, but they can also be found in the central nervous system. How they get there, of course, is a relative mystery. I'll be talking about that. But they have been found in regions of MS demyelination, and they can remyelinate those areas, which is very exciting. In addition, they produce growth factors that improve axonal health. In other words, they can improve the health of nerve cells. They release bundles of proteins, which are called exosomes. This will become a major research area, I believe, in the next several years. These bundles of proteins, called exosomes in the case of Schwann cells, contain axon-nourishing nutrients and anti-inflammatory proteins. In animal models, Schwann cells have been transplanted to areas of demyelination in the central nervous system, and they clearly can repair and remyelinate. But unfortunately, mature Schwann cells, as opposed to immature precursor cells, don't migrate and don't survive in the central nervous system. So immature Schwann cells can migrate and do survive, but what keeps them from getting into the brain? Well, astrocytes have a role to play. They squeeze the environment in such a way that cell migration is very difficult. And intact myelin, as well as myelin proteins, are actually, in some instances, toxic to Schwann cells. Yet some do enter the brain, and how is this done? And this is the exciting part about this particular paper. Schwann cells are able to move into the brain by traveling along blood vessels. And this is important because in areas of myelin loss, new blood vessels are formed. Various chemicals, such as cytokines, TGF-beta, for example, are produced by inflammatory cells that are in the brain at sites of demyelination. And interestingly, these cytokines inhibit oligodendrocytes, but stimulate Schwann cells. So this is just a schematic showing you different ways that Schwann cells can enter the brain via the vasculature, via the blood supply. So blood vessels at sites of inflammation in the brain produce cell-attracting proteins. If you have inflammation in the brain, the blood vessels, the endothelial cells change. And what is going to be possible, I think, this has not been done, but I'm very excited about the potential for this happening, using cutting-edge molecular technology, such as CRISPR-Cas9, I'm sure you're familiar with this. You can actually tweak the DNA of immature Schwann cells in such a way that they can recognize sites of inflamed blood vessels, inflamed endothelium, which will allow them to enter the brain and myelinate MS lesions. This has not happened, but I feel the potential for this is quite enormous and could prove to be a very important therapy. Finally, let me talk about gold, in particular, nanocrystalline gold. Now, we know that gold is a basically inert substance. It doesn't corrode, it doesn't interact chemically with other substances, but if you make tiny particles of gold, tiny particles, they act as a catalyst, and they greatly help in chemical reactions. As a matter of fact, these nanocrystalline gold particles have been used for years commercially in enhancing commercial chemical reactions. So with the new technique that was developed, you can now make gold nanocrystals only 13 nanometers in size. A nanometer is a millionth of a meter. For comparison, a human hair is 80,000 to 100 nanometers in size. So what do these gold nanocrystals look like? These are pictures of gold nanocrystals. They're polyhedral crystals. You put them into water, and the solution becomes dark purple or red, and you administer them by drinking them. So experiments have been done showing that if you drink gold nanocrystals, you actually change genes in a way that increases the metabolism and provides the particular environment with nutrients that are essential for oligodendrocytes to produce myelin. This results in the activation of myelin synthesizing genes. And what has been shown now is if you look at this melange of nutrients in the central nervous system of MS patients, they're deleted, in particular this one nutrient, NAD+. So this limitation of nutrients in MS brain may be one reason why oligodendrocytes are unable to remyelinate the areas of tissue destruction. So what did the scientists do? Well, they worked with an animal model, and they destroyed myelin by the injection of one of two chemicals, either cuprazone or lysolecithin. And I believe, yes. So as a result of the injection of these chemicals, you lost myelin, you destroyed oligodendrocytes, but you did not destroy oligodendrocyte precursor cells. They then fed mice either solutions of gold nanocrystals or water, and found, much to their surprise, robust remyelination. And again, I seem to be stuck here, so please help me. So this is remyelination after cuprazone on your left. On the top box, you see the group that was fed water. We're looking for black circles. These indicate myelin, and you can see the lower two boxes of mice that were fed nanocrystalline gold have large numbers of black circles around axons. On your right, you see remyelination after lysolecithin. The blue box on the left is the control animals fed water. You don't see much in the way of dark blue. On the right, you see the box, which is the tissue representation of mice fed nanogold particles, you can see a lot of dark blue remyelination. So I went to a recent meeting, and at the meeting, they presented preliminary data of a human trial. This is a study called Visionary MX, in which nanocrystalline gold is being used to treat remyelination failure in persons with MS who have chronic optic neuropathy, chronic optic nerve damage. And this is the poster that was presented at the meeting. I know you can't see details of it, but I'll go over it with you very, very briefly. Basically, this is a trial in which 5 parameters of MS function are being studied. The main parameter is, of course, vision. They checked visual contrast sensitivity, visual acuity, but in addition, they're checking memory function as well as upper hand function with the 9-hole peck test, as well as walking speed. And I understand that you can't read all of this, but you can go back and magnify it. Basically, if you look at the red dots, the very preliminary data suggests that administration of nano gold crystals, nanocrystalline gold, may have a beneficial effect, in which case this would be the first demonstration of this particular therapeutic mode being used to help tissue repair. So the implications are enormous. It seems like we're going to have an MS therapeutic disease cocktail. You'll have to have disease-modifying therapy to modify the immune system. You're going to have a disease-modifying therapy to address cells other than the immune system, such as astrocytes that may be participating in tissue destruction. And you're going to have a third disease-modifying therapy that will enhance remyelination and tissue repair. So all in all, a very exciting time for MS research, and I urge you to go back over my slides if there are any particular issues that I didn't explain as much as I would like. At this time, I'd like to hand it over to Randy to begin our first question and answer session.
Well, thank you, Gary. Our panelists are all here to answer questions, and we have a few questions that have been brought in and on our 2 talks. And we'll have another question and answer session a little later on as well. So I'll take a couple of these, and then I'll give to you a couple of these questions as well, Gary. And if more questions come in that are appropriate, we'll be glad to try to answer those as well. So one of the questions that came in says, does atrophy occur due to innervation even if you exercise? And atrophy, the shrinkage of that muscle, because of many different factors, can occur because of disuse, and that will respond to exercise. But in fact, if the nerve supply to that muscle is impaired because of multiple sclerosis and the demyelination, the atrophy will occur, and it'll occur naturally even if you exercise. But by exercising that muscle, not to the point of fatigue, you can maintain as much strength as you possibly can that way. So somebody said, if you use an external electric nerve stimulator, does that decrease atrophy? Well, it would if you used it a lot, but it doesn't. That's not very practical to stimulate the nerve externally yet. Transcutaneous nerve stimulation is something that we do at times. Certainly we do it for injuries, and we do it for functional electric stimulation, that is getting the nerve to work by bypassing the brain and spinal cord. So now, Gary, you can see the questions there too? Can you, Gary?
I cannot see the questions, no.
Okay. So,
wait a second, maybe I can. Hang on a second, I have to go up.
It says, why isn't Nerf2 approved for humans? That's the first question.
Why isn't NRF2 approved for humans? Well, it's a gene, and you can't really administer a gene at the present time. You can administer DNA, you can vaccinate with DNA, but it has to find the right cells. What has been shown is that you can administer some of these nutrients, which are necessary for oligodendrocytes to produce myelin, and that might be a way to increase myelination. But the important thing is to figure out why these genes are being activated in the first place. And for that, we have to understand the underlying disease process. What is so difficult with MS is that the disease process evolves over time. In other words, what happens at the beginning of MS is very different than what happens after 10 or 15 years of disease progression. So it becomes very difficult to identify the changing pathology of the disease, but it's happening. It clearly is happening, and as I said, we'll eventually have to have a cocktail of disease-modifying therapies to address the really multifaceted pathologic changes that are occurring.
Thank you. Another question is, who develops the various treatment plans that I was referring to? And we're talking here as a consortium of multiple sclerosis centers, which means that we look at the team approach to MS. And so we have people, physical therapists, occupational therapists, nurses, neurologists, rehab people of all sorts that are involved in developing a treatment program. So somebody has to be the leader of that team and develop the program. When I was practicing actively, it was me who developed that in consultation with my team members. In some other centers, it may be somebody else. But it does take a team approach to dealing with all of these types of problems. Gary, can a fecal transplant be considered to alter the gut biome in MS?
Well, that's an interesting question. Fecal transplants from a normal individual, that's been done in experimental animal models, and it works. We don't understand enough about the bacterial changes that occur in MS at the present time to make this a routine thing. What we need to do, rather than sort of do a fecal transplant, which contains millions of bacteria, is to identify those particular bacterial populations, such as Butyrococcus, that may have a specific therapeutic benefit. Until we do that, until we really understand what the populations of bacteria cause and how they change during the progression of disease, I would say a fecal transplant would have to be considered as part of a clinical trial, but it couldn't be done as a routine therapy at this time. That could change, but at the moment it would have to be experimental. We don't know enough about really what's going on.
That's a crappy answer. Well, we'll move on to the next. The next question, can you elaborate on the different types of fatigue? Can you suffer from many at the same time? And I always like to talk about 5 different kinds of fatigue, and I'll do this really quickly now because time is moving on here. We only have 4 minutes left of this. But people with MS can have normal fatigue. They can have a neuromuscular fatigue. That is, when you're walking, the nerve conducts, and then blocks, and then you can't walk as well. So that's a different kind of fatigue. You have the fatigue that occurs because you're deconditioned and you haven't exercised enough. You have the fatigue that occurs because of medications that might be involved. And then you have the fatigue that we call lassitude, which is the most common kind of fatigue, an overwhelming tiredness that hits people for no particular reason. And they each have a different treatment plan associated with them. So we look at the fatigue and then develop the treatment plan. Okay. Then there's another question here that says, does plateau mean no relapses or no progression? Well, I'd like to say that it means nothing happens to us and everything is absolutely stable all of the time. But the reality is that there is progression because we're getting older. We're getting older. So plateau to me means that you're not having relapses and you're not having progression due to the multiple sclerosis. And that's what we'd all like to see. We'd call that a cure maybe, and maybe our bodies will help do that in some people, but we need to do the things that we need to do to try to stimulate us to be as good as we can with what we've got. Let me see here.
I'd like to answer this one about the neurofilament light chains, if I may.
Thought we did that one.
When will this be commercially available?
I can see it. Yes, good.
Is it okay if I answer it, Ramsey?
Absolutely, go for it.
It's really an important question because it is another way of monitoring the disease without doing MRI scans. since it's extremely sensitive, it is available. The technique is called Simoa, and it's highly, highly sensitive. It is available commercially. Will it be paid for by the insurance companies is the key question. You know, these are not super expensive tests, not as expensive as MRI scans, but they do cost money. And at the present time, the assay of neurofilament light chains is considered an experimental procedure. But if it has been shown, if it continues to be shown to be useful in measuring disease activity and in then making treatment decisions that are beneficial to individuals with MS, it will become a insurance paid for assay and will become extremely valuable. So the possibility exists for it to be available commercially, and hopefully this will happen very, very soon.
So Patty, I'd like you to chime in on the electric nerve stimulator in terms of atrophy for people. Do you use that technique in your therapy?
I do, Randy. Thanks for the question. But you're absolutely right. You're dealing with a loop when you do electrical stim that really just helps make the muscle bulkier. But unless you can actively use that muscle in function, then you really won't get the strength to it. Now, it's a really advantageous tool if, say, for somebody who's really, really weak in their lower body and they want to do exercise cycling as a way to kind of build up their endurance and manage some of that deconditioning fatigue. You know, we can couple electrical stim with cycling to help kind of generate that endurance in the muscle that we need. But unless you can really translate that electrical stim and activation through the electrical stim into function, it becomes, you might have more bulk, but you might not have more activation actively.
Great. And Peter, I'd like you to comment on, do you use plasmapheresis for treatment of MS, and does it help with MS attacks?
Generally, plasmapheresis is used, in my experience, as rescue therapy in people that have not responded well to IV steroids for acute exacerbations. There's very little data that chronic plasmapheresis treatment does any good with respect to long-term management for patients with multiple sclerosis. So in my practice, we don't use plasmapheresis as a chronic therapy, no.
Thank you. And the last question, Gary, I'll throw back to you. Can you talk a little bit about stem cell research very briefly?
Well, you know, that's a very generic topic. What kind of stem cells do you want to put into the brain? Will they find their way into the brain? Once you put them into the brain, will they do what you want them to do? I think what I talked about in terms of Schwann cells, you can consider them, if you will, stem cells. They're precursor cells that have been differentiated into Schwann cells. If they can be manipulated to enter the brain via areas of altered brain blood vessel endothelium, that could really be a very major adjunct to the treatment of MS, because Schwann cells in the brain, once they're there at sites of demyelination, do have the capacity to heal and to remyelinate. So if I were to choose one area of stem cell research, I would work on getting Schwann cells into the brain, because they really do a fantastic job, in some ways much, much better than oligodendrocytes in terms of their ability to survive.
And then a brief comment on stem cell rescue therapy with hematopoietic stem cells.
That's the bone marrow transplant you're talking.
Yes. Yes. Comment on that, please.
Well, it's called rebooting the immune system, if you will. That's a whole different concept. You don't really address the brain per se, you address the immune system. The theory being that in people with MS, the immune system is sufficiently abnormal where no matter what you do to control it, there'll be abnormal cells attacking the brain. So if you can just revamp the entire immune system, you take stem cells from the bone marrow of an MS patient, you eliminate the old immune system with various chemotherapeutic agents, and then you infuse the new stem cells, they will regenerate a pattern of immune response that will protect the brain. And there are data to support that, actually. The question arises, why was the immune system abnormal to begin with. Well, is there something in the MS brain, perhaps, that might stimulate the immune system to do abnormal things? And that, I think, is a whole other issue that I'll actually be talking about in my blog in the next week.
Very good. And I'll just add to this, getting stem cells injected into your butt is of no value in multiple sclerosis. Suffice it to say now, our session will move on. Before we move on to Dr. Wade's talk, let's recognize our next supporter.
The Consortium of Multiple Sclerosis Centers and Catamount Medical Education would like to thank Genentech for their generous support of this program. This support has made it possible for us to provide this valuable educational program for people living with MS and their care partners.
Good afternoon. My name is Peter Wade. I'm a neurologist in Hartford, Connecticut, and I run the Mandel Comprehensive MS Center. And I'd like to thank Randy for inviting me to speak on this very esteemed program today. This is a picture I took when my wife and I were on vacation in Hawaii on her 20th wedding anniversary. Very important in patients with MS to have a very supportive family during times of difficulty. And I think that my wife is a very important part of my life on a daily basis, helping me deal with the issues we involved. So when originally Randy had spoken to me, I had come up with a title slide, and it was going to be personal and professional perspectives of MS. I've given this talk at other times. But when the slides came out, when the program listing came out, that slide was actually perspectives from a neurologist who has multiple sclerosis. Generally, when I give this talk, I really don't start with the letting everybody know that I have MS. It kind of comes up as the talk has gone on. But given this, it turns out this is a better explanation for what has happened. The cat's kind of out of the bag. And so from the beginning, we'll start this program with acknowledging that I've had MS. What I like to do with this program is to kind of just go through my history, my time with MS, and at points in there point out aspects and things that I can help people learn a little bit about. So what I know about multiple sclerosis and multiple sclerosis care, starting in 1975 and through today. So in 1975, I was a college freshman. I was going to college to play baseball. I had really no interest in academics whatsoever. And I lost the vision in my right eye during the baseball season. I was diagnosed with idiopathic optic neuritis. A lot of MS patients present with this. You lose the vision in your eye, you can lose your color vision, you get pain with eye movement and things along those lines. It's the term idiopathic means the idiots don't know what's going on. That was the reason. They don't know the cause of optic neuritis. The treatment at that time was rest. There was no disease-modifying therapies or even steroids. And I'd lost my depth perception and acuity. I didn't recover completely, and so I was unable to play baseball. That was my plan, was to play baseball as long as I could and be a high school baseball coach. That was plan A. So I came up with plan B, which was to transfer to another college in a pre-medical education program and attend medical school to go and find out why this had happened to me. In 1975, I actually had a CAT scan. They were discovered that year. It took 6 hours to do, always broke. We had to go 6 weekends in a row to have it done. And actually, it's interesting because back then the technology was used a Polaroid camera and you took a picture of each of the pictures on a TV screen. That's why this looks exactly like a Polaroid camera. Up in the left corner, you can see the date is October of 1975. This CAT scan will come up later in the talk. So during the second year of medical school, I had double vision, trouble reading and driving, and I was diagnosed with multiple sclerosis. Actually, I was during the neuroscience course in medical school when this happened, so I sort of diagnosed myself with multiple sclerosis because I'd had my second attack. I had good recovery. It took about 6 weeks to get better, and I had my answer, multiple sclerosis. So at that point, I told my father I wanted to withdraw from medical school because I really didn't want to be a doctor. I just had wanted to know why I couldn't play baseball. I, however, was urged to continue medical school. So at that time, after I graduated from medical school, my father was a surgeon. I had kind of a surgical personality, and I thought about neurosurgery, but that had too much risk if I had any further MS attack. And because I had eye problems, I thought I'd be an eye doctor, but they didn't match for the residency because of my eye problem. So then you need to do something after you graduate from medical school. So I did internal medicine for 3 years. During my internal medicine residency in 1984, I had another MS attack in which I had paralysis in my right leg. I couldn't walk. My arm was clumsy and heavy. Another exacerbation of MS. The treatment again was more rest. The outcome, I was unable to work for 6 weeks, but I had a fairly good recovery remission, and I was able to return to work and continue in my medical training. So after I finished internal medicine, which I really didn't like, the people that I didn't mind getting up for when I was on call were neurology patients. So I thought maybe I could do neurology. I was at Georgetown for 3 years as a neurology resident. During my residency, I had another attack, left leg weakness. This is the first time I was treated with IV Solumedrol. That was given in the emergency room at that time, over 5 days, and more rest. I had my first MRI scan at that time, and I made a good recovery within 2 weeks, and I missed only 3 days of work. So this was a fundamental change in that you could take steroids and get better quicker. Instead of being 6 weeks without any recovery, it took only 2 weeks to get better. So that was very exciting. So these are some information on MRI study. MRI scans take a long time because they take different pictures. There's what's called T2, which shows any type of pathology. You can see that arrow pointing to that white spot. That's an MS lesion. Then there's flare. What happens with flare is you subtract out all the spinal fluid so that the white areas are areas of inflammation. This is a more sensitive scan. Then there's T1, which shows anatomy. If there's a scar or an injury, it causes a hole. You can see on that scan some of the little round holes that they're present. And then finally, there's injections of gadolinium. That's when they inject the dye into your vein that floats around in your vein and leaks into areas in the brain which are inflamed over about 6 weeks. So these are the different types of scans that people have done. That's why it takes a while to have an MRI scan. So now I'll show you my MRI scan. This is a scan from the top. Nose is on the top, ears on either side, and you can see the little white lesions. This is a flare scan. This is another scan a little bit lower down. Those two black areas in the center are called ventricles, and that's where spinal fluid is made. So that's why we do spinal taps. So we can take the spinal fluid from your lower back where the fluid leaks to the area, and it gets reflected in the spinal fluid near those lesions. So that's why about 9 out of 10 patients with definite MS, the spinal fluid will be abnormal. So that's helpful for diagnosis. Now this is a scan. You may see the little white worms on this scan. This is a scan that I've been given gadolinium, and you can see there's several black holes on that scan. Those are the permanent scars of MS. If one of those was acute or new, the dye would light it up. So that's what an MRI with gadolinium can show, things lighting up, and it can also show scars on the black holes. This is a scan from the side, and you can see 3 lesions, one that looks like a thumb, one that looks like a shark fin, and a third towards the right. Now, if you take that scan, that's a flare scan. If you look at a T1 scan, you can see that area which was the shark fin is completely damaged. That's a permanent area of injury. But the one that looked like a thumb isn't as completely damaged. So some lesions scar and turn into black holes. Other lesions can heal to a degree, and that's why you get some degree of remission. So now it's 1988. I finished my neurology residency. I turned out I enjoyed neurology, so I decided I'd continue to be a doctor. But I really didn't want to take care of MS patients. I didn't want to see my future with MS. And so MS is a white matter disease, the wiring of your brain, and seizures are gray matter disease, the brain cells. And so I went to Yale to do epilepsy fellowship to study seizures so I'd not have to see MS patients. In 1990, that was now after 4 years of medical school, 8 years of training, my wife said, maybe you could get a job. I was 32 years old, and so I joined a private practice in Hartford, Connecticut, just doing general neurology without any focus on multiple sclerosis. In 1996, my right leg would continue to fatigue with exertion and hot weather. People see that a lot. I consulted an MS specialist. I started injection therapy without any type of physical therapy to help with my leg. Because at that time, physical therapy was thought that it could help you recover more quickly, but it wouldn't make any difference in the long run whether you got better or not. That was my training about physical therapy at that time. So now we moved 10 years later to 2006. I'm in practice in Hartford, Connecticut, doing general neurology. My right leg spasms at night, disrupting sleep. The little asterisks that also disrupt my wife's sleep, because if your legs jump the person you're sleeping with, it keeps them awake at night. So I saw another MS specialist. He examined me and found that I had spasticity or stiffness in my right arm and leg, and I had a Babinski sign on the right. That's the time when the doctor takes his usually tuning fork, a reflex hammer, and scratches the bottom of your foot and sees which way your toes go. When you're born, your big toes curl up. At about a year old, your big toes curl down. And for the rest of your life, they should curl down. One of the signs of injury to the nervous system is the toe curling back up, and that was present on the right side of my leg. So I continued on the disease-modifying therapy, and he started medicines for spasticity and restless leg syndrome. Those are symptoms of consequences of MS lesions, and you need to use symptom management along with just disease-modifying therapy as a complete approach to treat the disease. I had my first MRI scan of my cervical spinal cord, but again, no recommendations for therapy, physical therapy or otherwise, just treatments with medication. Now, this is my MRI scan of my cervical spinal cord. You can see the spine bones and the discs in between. Then there's the spinal cord, and you can see 3 white lesions within my spinal cord. That's why I had the spasticity in the toe going up. So 2007, what I'm doing is I'm an adult neurology practice with about 160 MS patients that I've accumulated over the years. I share my history of MS with my patients and my families, their families. It was therapeutic for me and for them to have someone understand what they're going through. Disease management consisted of therapeutic medications. No additional physical therapy, occupational therapy, or speech and language therapy was utilized at that time in our practice. Now, as a member of the Board of Trustees of the Greater Chapter of the Connecticut National MS Society. Then there was a bump in the road. Now, remember that CAT scan of the brain that I had back in 1975? Well, in the spring of 2007, I volunteered for a new type of CAT scan at the hospital that examines your chest and looks at the arteries in your chest, your coronary arteries. Because I'd had that scan almost 30 years ago, I said, what the heck, I'll volunteer for the test. I was the first person ever to have a cardiac CT scan at the hospital. The results were very, very surprisingly showing that I had a major artery narrowed in my heart, one of the coronary arteries. I have no risk factors for heart disease. No one in my family has ever had any heart problems. So the next day I had this treadmill stress test. Usually you walk on that and then you run. I failed that after 2 minutes because it looked like I was having a heart attack, even though I was having no symptoms. The next day I had a cardiac catheterization and all the arteries in my heart were severely narrowed. And the following day I had 5-vessel emergency cardiac bypass surgery, likely saving my life. If I hadn't had a CAT scan in 1975, and if I hadn't volunteered for that test, I probably wouldn't even be here today talking to you. It's an amazing miracle of coincidence and things that happened in my life to get me here today. So in the summer of 2007, the Mandel MS Center was proposed as a comprehensive clinical research center for patients with MS at the hospital where I work. I was asked to be the medical director for neurology. It was unknown to any of the people involved that I'd suffered from multiple sclerosis. I'd kept that very quiet, just sharing in the history with my patients. I'd spent my entire life trying not to treat multiple sclerosis patients. I just wanted to play baseball. The Mandel Center opened in the spring of 2008. So 2008 to present, the Mandel model for comprehensive multiple sclerosis care has been developed. Mr. Mandel's wish was to have all of the services at one site. Mr. Mandel also has MS and is very generous. Each patient is seen as evaluation includes consultation with a neurologist, speech, occupational, and physical therapy evaluations as they're part of their first visits, consultation with a physiatrist to coordinate care for spasticity management. Additional services we have at our center are urology services, as Randy talked about earlier, pharmacy consultation services. People end up on a lot of medicines and can get very confused, and it's nice to sit down with a pharmacist and try to sort out when you're supposed to take your medicines, which ones are with foods, which ones are without. Social work services are very helpful dealing with the consequences and issues in your life. On-site infusion center just for MS patients. And research emphasizing rehabilitation outcomes and clinical trials. Our center is actually at an acute rehab hospital. And here's just some pictures of our center. When we redesigned the center, the columns were my idea because they need an entrance. That's check in and check out. That's the waiting room. Actually, we've now set it up for social distancing. The chairs are all 6 feet apart. That's our infusion center. There's 6 chairs there. It's now up to 14 chairs. And it's just for MS patients. This is one of the 2 gyms we have for rehabilitation and evaluation. This is the second gym. This is a really interesting machine. You stand on that little gray pad in the middle and that moves around like a Wii machine, and then all the walls move in that. It's a very sensitive way to assess for balance. And then we have a pool. This is one of those Michael Phelps type pool. You can swim against resistance, and we can change the temperature because the temperature, warm water and things like that can make people with MS have worse symptoms. Actually, the original screening test for MS was a warm bath test. You'd put a patient in a warm bathtub and see if you made their symptoms come back or if new ones evolved. And then this is a really fascinating piece of research equipment that we have, in which it's a motorized treadmill and a robot. And you can take someone in a wheelchair, put them on this treadmill, and then it teaches them to run again and walk. And this is a picture of someone with the robot attached to them, moving their legs. It's like a brain plasticity model where you can relearn to do things that you didn't do as well before. So in 2016, I had 2 separate exacerbations 8 months apart. Now that's after being diagnosed with MS in 1980, so that's 36 years later, still having exacerbations. I had poor balance. If I bent forward, I would fall forward, hit my head when I reached for things. I'd be starting to use the handrail when I'm walking in the hallways. I had a limited response to high-dose steroids. And at that time, there was very little chance for meaningful recovery of symptoms after several months. So you have to practice what you preach. All of our patients see the physical therapist, occupational therapist, and speech therapist. I did when we started the center. My physical therapist said, we can try to help you with your balance. And I said, okay, I'll try it. I had really little hope that I was going to get better, however. 3 months of physical therapy, learning a new way to feel your balance, a lot of focus on my feet, feeling my feet much better with parallel bars and a lot of pads and things like that. And actually, I had an essentially complete recovery of my balance. During that 2 exacerbations, it was really to the point where I thought I was going to have to stop working. It was very, very disabling. But with this, I was able to return to work and go back to caring for my patients. An underlying skeptic for physical therapy turned into a true believer. So now patients always ask me, because I'm the neurologist with MS, what medicines do I take? So I can kind of review my treatments over the years. The first treatment I had was what I call aggressive observation, or wait and see. When the first injections came out, my treatment from 1980 until the early 1990s was to ignore it. And I didn't want to take anything. I just would see how my patients did on it first. I had those exacerbations, and so I took various forms of injections. It was compliance and tolerability issues. I'm really not a big fan of needles. I took an infusion therapy and had a life-threatening anaphylactic reaction to it. I've taken the various oral therapies and had side effects or contraindications that I can't take it, like my heart disease limits it in some of those cases. Currently, I'm in infusion therapies and I find them tolerable and effective. So I've been through just about all of the therapies. So then the next question comes up: which medicine should you take as a patient? Well, I think there's 4 pillars to decide what's the right medication for you, and this is the decision you should have between yourself and your provider. The first is effectiveness. You don't want any more relapses. You don't want optic neuritis. You don't want any more balance difficulties. You don't want any new lesions on your MRI scan. And most importantly, you don't want any decline in your physical or cognitive function. Those are the parameters that the medications study, and that's what an effective medication would do. Then you want safety. You want to understand the risks of the medications pertaining to your health history and what issues might be important for your safety on the medication. The third parameter is tolerability. Can you put up with it? I was intolerant of injection therapies. That was just not something that was going to happen. I would have a refrigerator full of the injections because I just forgot to take them, so to speak. And then is compliance. Are you going to take it or not? So I think those are the 4 issues you need to put together when you're trying to decide with your provider what's the best medication for you. So in summary, from 1980 to 2000, this is 40 years. I've been living with the diagnosis of multiple sclerosis now for 40 years. My current position is the medical director for neurology at the Mandel MS Center. Remember, I just wanted to be a baseball player. We've seen over 3,400 new patients. I'm working with a staff of over 30 highly skilled professionals providing comprehensive care to patients with multiple sclerosis. Our team, as I like to call them, includes neurology providers, physical, occupational, and speech therapists, physiatrists, urologists, infusion nurses, pharmacists, integrated medicine specialists, and administrative staff, all under one roof. That was Mr. Mandel's dream, was to have everything on site, one site. You only have to park your car once. So 45 years later, it's been a long journey with many twists and turns. I ended up doing what I spent most of my life trying to avoid. It's the most rewarding time of my career, being able to help others like myself dealing with multiple sclerosis. and of course, the Boston Red Sox, who was my team, have won the World Series 4 times during my career. So this is the team I originally wanted to play for. This is actually in Fenway Park. There are these 5 cutouts, and then there was just a head and shoulders without a head, and this was for little kids. So I had to actually kneel down to get this picture taken. And one of the questions my wife always asks me is why you're smiling so much in that picture compared to some of our wedding pictures. And I said, is that a question, or is that just because this is what I wanted to do? But this is the team I wanted to play for. This is actually the team that I play for. This is our staff at the Mandel Center. So I'd like to thank you all for your attention today. I'd like to thank CMSC for allowing me to participate in this program, and for Randy and everybody else for allowing me to enjoy this. This is another picture where my wife went for her 25th wedding anniversary. So again, thank you very much. Our next video has been developed to honor those living with multiple sclerosis. Thank you for telling your stories, for your contributions to this program. Let's begin.
It is often said that everyone has a story to tell. Thank you to those who told us your story. You conveyed your struggles. Your optimism. Your determination. Your accomplishments. Your strength. Your hope. Your encouragement. And your courage to continue to thrive while living with multiple sclerosis. The Consortium of Multiple Sclerosis Centers and Catamount Medical Education would like to thank Mallinckrodt for their generous support of this program. This support has made it possible for us to provide this valuable educational program for people living with MS and their care partners.
We are so inspired by the stories of those in the MS community overcoming challenges on a daily basis. Among them are people of fame and influence, which brings us to our next interactive activity. In a moment, a slide will appear with a quote from a celebrity living with MS. There will be 4 celebrity pictures underneath the quote. Click on the picture of the celebrity that you believe the quote is attributed to. Again, there will be 3 rounds. Here we go. Which famous singer living with MS said the following? It takes a lot to conquer this disease. I don't think conquering it means curing it. I think it means not letting it break your spirits. The spirit is what keeps us going, and I think the spirit is what we need to find a cure for this. So, was this quote said by Alan Osman of the famous Osman Brothers? Or was it Alex Alexakis of the band Everclear? Was it this country favorite, Clay Walker? Or was it singer-songwriter Tamaya Hill? Ooh, looks like most of you guessed Clay Walker, and you are correct. Let's move on to the next quote. Which of the following famous actor living with MS said this? I just wish for people to understand that being honest and vulnerable actually increases connection. Your life is so much easier when you realize you have nothing to hide. We are all dealing with something. If we all shared our truest selves, our lives could be so much easier. Was it David Lander of Laverne and Shirley? Was it Jamie Lynn Sigler, most known for her role played in The Sopranos? Was it the hilarious Richard Pryor or the beautiful Terry Garr? Go ahead and vote. All right. Well, most of us thought it was Terry Garr, but actually it was Jamie Lynn Sigler. Good try, everybody. All right. Let's move on to the next and last quote. Which of the following famous influencers living with MS said, "You never know how strong you are until being strong is the only choice you have"? Was it author, philanthropist Ann Romney? Was it famous talk show host Montel Williams? News anchor and commentator Neil Cavuto? Or was it Richard Cohen, syndicated columnist for The Washington Post? Who said this great, inspiring quote? Wow. Well, not only is his talk show famous, but apparently this quote is, most of you guessed, Montel Williams, and he is the author of this inspiring quote. Before we move on to Patricia Bobrick's talk, let's recognize our next supporter.
The Consortium of Multiple Sclerosis Centers and Catamount Medical Education would like to thank Novartis for their generous support of this program. This support has made it possible for us to provide this valuable educational program for people living with MS and their care partners.
Good afternoon, everyone. Thanks for hanging in there. I'm going to be your relaxed lecturer before we have some more Q&A. I'm really very honored to be part of this distinguished faculty, and I get the joy of being able to present to you on something that I'm really passionate about, and that's rehab and wellness in MS. I work for the University of Health in Colorado, Yampa Valley Medical Center in beautiful Steamboat Springs, Colorado. So this is such a broad topic, as all of our topics have been today. So, I was thinking about it. Well, you're going to get an overview here, the 30,000 foot view. And when I really thought about it, this is going to be kind of like speed dating. I'm going to take you to a topic. We're going to spend a little time with it. We'll move to the next topic. And at the end of this lecture, I hope that you can find things that resonate with you that you can come back to and do a little bit more investigation. So here we go. So wellness, I wanted to spend a little bit of time to just define what wellness is. And one of the reasons is that I think that people who have a diagnosis of MS equate it with being sick, okay? So usually we think of wellness as the absence of disease. And I'd like for you to kind of broaden that or have a different perspective on that, because if you look at it in a larger way, you can think of it as you are reaching your highest potential, your fullest potential, whatever that potential may be. So we're looking more at mind, body, spirit, all of those things combined. And you can have a diagnosis of MS and still be healthy. So that may be a new concept for you, and I want you to kind of think about that as we're talking about some of these topics today. Usually when I start talking about wellness, or I bring it up with somebody living with MS, I can just see them rolling their eyes, and they go, oh gosh, this is where she's going to tell me these are the kind of foods I'm going to have to eat, and I'm eating the wrong foods, and I'm not doing enough exercise. And that seems really very punitive and very negative. And I want you to think of wellness as embracing something positive and something very affirming. We all have a personal responsibility for health essentials, and it's very closely related to our lifestyle, how we live our lives. Are we active? Have we always been sedentary? Do we like to be in sports, or are we just happy to sit and read a book? So I'm going to go over a few topics here. We're going to talk about nutrition, again, an overview of nutrition. We're going to talk about hydration, weight control, certainly exercise, because that's my wheelhouse, and controlling any other factors that contribute to our lifestyle, either to its betterment or endangerment. So we're going to go right into nutrition. So instead of kind of going through each diet, although I have a slide on a list of diets and we'll talk about them briefly, I want you to think about how nutrition may actually impact your MS. And these are ideas that we haven't fully fleshed out with our research yet. So I just want you to think, okay, I'm putting fuel in my body. How might that help my MS? Well, one way it might help your MS is that there is a direct effect on the immune system. So the metabolites, the things that we put on our body, have a direct effect on those immune cells, and then can impact how your MS reacts. Dr. Birnbaum did an excellent job talking about this gut flora and this gut microbe. So we do have this kind of environment in our gut that communicates with our immune system. And if we put different food in our body, can we kind of shift that flora to a more anti-inflammatory kind of environment versus a pro-inflammatory environment, which is not what we really want. And then the last effect that we might be able to look at is, can nutrition have a direct effect on the brain? Like we hear about, oh, that's brain food, Can we directly affect those cells in the brain by what we put in our body? And that's where the research has been going of late, in those different areas, to see what kind of impact we might be able to have. Really interesting story about kind of opportunities on where we might be able to do better in our health and wellness. It's a study from 2016, and they surveyed people living with MS, and they asked them about their diet, and they asked them about their exercise. And what they found was that over 85% of individuals living with MS, if they looked at diet alone, were not meeting the daily dietary guidelines. And if they coupled that with exercise, were they also getting the right amount of exercise that they needed? More than 90% were not. So again, I just want you to kind of think about that. Is that an opportunity that you can do something more positive for your overall health and wellness? So diets, just to name a few. When you say the word diet, people go, oh, diet, oh, this is, so inhibiting, and I'm cranky and all of this. And so I'm going to go through these just very briefly, but I want you to think kind of a common theme of it, and we'll talk about that at the end. The paleo diet kind of has this mindset that we're not evolved enough that our systems can handle all that processed food that we're eating, so that we should be eating like game and eating like hunters and gatherers. So more berries and plant-based foods, no eggs, no dairy, things like that. The Walls diet has been brought forward by Dr. Terry Walls, who's living with MS herself, and it's a version of the paleo diet. The recommendation is that there is grass-fed meat and wild fish at every meal, and a total of at least 9 cups of vegetables every day. The Mediterranean diet, again, it's another kind of version of the paleo diet. They're pretty high on whole grains, get to have some olive oil, lots of fish. The one kind of plus that is attractive to some people on this diet is that you're allowed red wine, some ethanol in there. So that usually maybe makes that a little bit more palatable of a diet for some people. The McDougall diet, it's a low-fat, high-carb diet. The gluten-free diet, really, it is developed for individuals who have celiac disease. And there's no evidence right now that gluten-free diet has been beneficial to MS. But I put that up there just because so many people feel that they're gluten sensitive, even if they don't have celiac disease, and that might be a healthier dietary tract for them to take. The Schwann diet has been around for a lot of years, and basically it's really limiting the amount of fats you have, really low saturated and unsaturated fats, and they ask that you have no meats for the first year. And then we've all pretty much heard of the American Heart Association diet, the food pyramid. They actually have shifted the food pyramid where it used to be kind of this stacking one on top of each other, the foods that we should have the most of. They kind of shifted it, turned it on its side, and now there's slivers. But all of these diets have something in common, and that's there's not a lot of processed foods in these diets. So let's talk about what we do know, or at least what we think we know so far, because things are evolving, things are changing, and we're learning more and more over time. So right now, as of right now, there's no one diet that has overwhelming evidence or really strong evidence that that's the diet you should be on for your MS. Okay. Like I said before, all of these diets have a common theme that you're not eating a lot of highly processed foods. So you might take that away from that. We know that obesity is a possible risk factor for developing MS. So it's a risk factor if you have a high BMI that you might be diagnosed with MS. Sodium, we think, also plays a role. If we have a higher intake of sodium, then there may be a higher risk of having more relapses or even the development of new MRI lesions. So, a lower sodium diet is recommended. It doesn't have to be no sodium, but just not a high salt diet. We know that low levels of vitamin D can influence not only the disease onset, but disease progression. Your physicians are checking your vitamin D levels, and if they're low, you're being supplemented. There's also some research to suggest that polyunsaturated fatty acids, those PUFAs, may have a role in helping slow disease activity. So things like those fatty fishes, salmon, deep water fish, omega-3 and omega-6 vitamins may be mildly beneficial for your MS. And there's been some research on biotin. Biotin is a form of vitamin B, and it may have a possible effect on disability in high doses, but there's a big asterisk on this. High doses of biotin can mess kind of with your lab work, so you could get some false negatives in labs, and you could have a treatment plan that may not be appropriate because it was skewed by this. All of this should be a conversation with your healthcare professionals. You shouldn't leave this talk from me and say, oh, I heard biotin is good and I'm going to go take a bunch of biotin. This is always a conversation with your healthcare professionals. And I can, as a physical therapist, can talk to you about good nutrition, but I also feel that it's really important to bring in those other team members, that comprehensive team, that people who are more skilled in that area, so nutritionist or dietitian, to talk about what your particular needs are and what would be best for you. So what's the practical takeaway from this? Well, the practical is, if you showed a food to your great-great-grandmother, would she have recognized it? So if I showed my great-great-grandmother a Cheeto and a Ding Dong, would she say, oh yeah, I had those for breakfast? Probably not. So if your great-great-grandmother wouldn't recognize it, it may be something that you may not want to be putting in your body. Another tip is that if you shop the periphery of your grocery store, you're probably going to make better choices. And think about that, whether you shop at Publix or Safeway or wherever. Grocery stores are usually set up in a similar fashion. You have around the periphery fresh fruits and vegetables, you have meat and dairy, poultry, fish, and those are the things that are in the periphery. So less of the processed foods are distributed there. So you may be making just better choices by kind of staying on the outside of the store. If you can, avoid fast food. They usually are highly processed. They are usually high in fat. They're calorie dense and nutritionally sparse. Now, some fast food restaurants, have added to their menus some healthier choices, and I never have this hard fast rule, like never go to a fast food place, because what if you're just too fatigued to cook? It's important that you have some nutrition. So if you do fast food, look for those more healthier options. Places have salads now and apple slices and yogurt and some things that aren't fried. So just kind of look and search or ask what's on their healthier menu. And the last kind of recommendation or practical tip is that you drink enough water. And we're going to actually spend a little bit of time talking about hydration. Our bodies are a lot of water, 75% water and 25% solid matter. And we need water for all of our body functions. We need it as nourishment. We need it to eliminate waste. And basically, the water has to be present for all the processes in our body. So if you're having a hard time getting in your fluids in a day, you might think of water as a nutrient, as a treatment for you, that this is important for your overall health and well-being. Beverages, besides water, count towards your fluid count during the day. But if you're drinking a lot of things that have a lot of caffeine in it, a lot of alcohol or sugar or artificial sweeteners, those things can have a very dehydrating effect on you. And that's not good. You're going to end up kind of with this imbalance that there's not enough actual water in your system to do what you need to do. And also, caffeine can, in particular, act as a diuretic and a bladder irritant. So, if you already have bladder issues and you're having urgency and frequency, now we're adding things that are bladder irritants or might have you not be able to eliminate as well. You might want to look to see what you're drinking and how much you're drinking. And if we don't drink enough, we're actually building up toxins in our body. So I didn't put this slide up here just to kind of talk about these bullet points, but as you're looking at this slide, these are signs of dehydration. And as I looked through them, I thought, sign of dehydration, lack of energy. Well, lack of energy is an MS symptom also. Muscle cramps. Well, muscle cramps is sometimes hard to distinguish between that and spasticity sometimes. Fusion, kind of a mental fog. Well, that can go along with an MS symptom. Our inability to sweat, our sweating mechanism is really important, especially if you have thermoregulatory impairment. Like if you're very heat sensitive, then sweating is one of our ways to cool our body temperature down. And if we're not sweating, then that's something that we've lost as in our kind of toolbox to manage that symptom. And also weakness. So, I'm not saying that water is the solution to all of your symptoms, but if you're not getting enough hydration, they may be contributing to things that you're already experiencing that you have been blaming all along on MS. And then usually what the next question I get is how much water is enough? And, you might see in literature, okay, you've got to drink 64 ounces. Well, that might be right, but usually it depends. It depends on what the temperature is. It depends on how much you're sweating. Are you exercising a lot? Are you, dissipating a lot of those fluids through your perspiration? The best way to really tell if you're drinking enough is to look at your urine, okay? If your urine is clear or a slight slight yellow color, then you're probably drinking enough. But if it's a dark yellow, even sometimes to an orange, then you really need to be looking at how much you're drinking. The flip side is also true. You could also drink too much. And I have had people who literally drink gallons of fluids a day, and they end up with some electrolyte balances because they're really flushing a lot of that out. So drink some water. I hope you're sipping on some right now. The next topic I have for you is really my wheelhouse, exercise. And again, I am appreciative to the speakers who came before me, who really see and promote the benefit of exercise. Was not popular early in the day. When I first started practicing years and years ago, usually people came to me because they got a referral because they needed an assistive device, or that their balance was so off that they were falling quite often. But now a lot has changed, and I get referrals right away to help people develop a sound exercise program, teach them how to exercise properly. So that's part of the treatment plan as we go along. And I'm going to briefly talk about stretching, strengthening, aerobic conditioning, balance re-education, and functional training as the kind of combination of exercises you should be doing. But really, when you approach exercise and you say, oh, Patty, I just don't exercise. I don't never exercise. It's just, it's just not what I do. But if I start reframing that for you, and you think of that as just part of the overall package of what you do for your MS, it's not another pill that you have to swallow. And I'm not saying that having medication is not good. It is good. This is an adjunct to that. And this treatment of exercise has very little side effects, then or no side effects, then you'd be all over it. So, think of it as just another way to help deal and manage your symptoms and staying healthy. The next two slides are really just a couple of documents that I wanted to kind of share with you as a starting out point for exercise. Really, my recommendation always, and strongly I recommend this, is that even if you're diagnosed and you have little or no symptoms, that you meet with your rehab team so that they can establish this baseline data, and that we can talk about what would be appropriate exercises and what to look out for while you're exercising. So not only what to do, but how to do it and how to do it safely. But there's a couple good documents just kind of as a springboard, because people say, well, I don't know how much I should be doing. This is from the Canadian Physical Activity Guidelines for Adults with MS. So adults 18 to 64 years old who have mild to moderate disability with their MS. The recommendations is 30 minutes of moderate intensity aerobic activity twice a week. We'll talk a little bit more about that, what that means. And strength training for the major muscle groups twice a week. And they did some research to support this, and they found that folks who followed this the majority of the time had improved their fatigue, they improved their mobility, they enhanced their quality of life. So that's a kind of a nice way to kind of just, like I said, a springboard to know what you can do. Now, this is literally hot off the presses. This was just released. And this is exercise and lifestyle physical activity recommendations for people with MS throughout the disease course. So the paper talks about recommendations from start to end, and it breaks it up into the different EDSS groups. And if you don't know what the EDSS is, it's a scoring mechanism that we can score someone living with MS to say where they are in their level of disability, and it gives recommendations in the different categories. But if you notice, the very first bullet point in this is that the recommendation is that you meet with a rehab professional that knows about MS so that they can make the program individualized. And it's really, really key that you do that. And the other really nice factor is that if you establish that relationship really early on and there's a connection there, then that person can follow you throughout the course of you living with MS. So they're the person that you can go to ask those questions that you have about exercise, or make recommendations about a different type of exercise if you decided, well, I want to try this machine or I want to try this activity. Do you think that's appropriate for me? And if you've already established that relationship and your therapist knows you, then they'll be able to do that for you. Back to the recommendations. The recommendations say that individuals living with MS should have more than 150 minutes of exercise and or physical activity. So that could be gardening or dancing or active housework. All of those activities would add to those minutes. And also the disclaimer, or the thing that we really need to pay attention of, is that no one is going to start out at 150 minutes. Well, maybe you are, but most of you are not. And so the goal is to really gradually, look at what your symptoms are, look at what comorbidities you have, and how can we get you kind of more towards those minutes versus I'm going to do 150 minutes in 2 weeks. I'm going to reach that goal. No, we're not training for the Olympics. There's no time frame. So whether it takes you 3 months to get to that recommended level or 3 years, as long as you're making forward movement towards that progression to that new activity level, then you're moving in the right direction. So stretching, all right, and stretching can take a lot of forms. I mean, you can do just regular stretching, but you can do yoga and other forms of positional stretches, but you want to hold the stretches longer, and it's a really good tool for spasticity management. And a lot of times I get referrals from many physicians who want me to start an individual who's living with MS and spasticity is one of their symptoms, to put them on a stretching program first before they put them on a medication, to see how much we can manage with this tool. The longer you hold the stretch, the better. There are muscle bridges, and when you stretch quickly, they go back quickly. But if you stretch longer, they're elongated and they're held out there longer. So that's what we want. I usually recommend stretching daily because it just keeps you in the mindset of kind of this exercise. It's low energy consumption. The next kind of type or mode of exercise is strengthening. And the recommendations, remember those recommendations about exercising and doing those major muscle groups. Well, if you can be reevaluated or evaluated by someone who knows MS, we can really identify the muscles that are deficient. And Randy mentioned this, muscles can be deficient, weak, because of disuse. Say you've had a flare-up and you haven't really rehabbed it fully, and there's more to be gained. We need to target those muscles so that you can get the most functional benefit. I'm always about getting the most bang for your buck. So if you're going to do an exercise, if you're going to expend some energy, I want to make sure that what you're doing is going to relate to something important in your life, an important function, whether it's walking or transfers or balance or any of those things. Sometimes the core is the forgotten area of our body, so don't forget to address your core. It's really our foundation, and it's where we need to really have good strength for our arms and legs to work well. Aerobic conditioning, that's to make us have a healthier heart and lungs, more endurance, stronger muscles. They're more efficient that way. And it also is a huge way that we can battle some of the fatigue that's associated with MS. One of the things that I think is most important in determining kind of what you should be doing in your aerobic conditioning is to see what's feasible for you. A lot of folks will recommend aquatic therapy, and I love aquatic therapy. Water is such a therapeutic tool. You move easier, you're freer, you can do a lot more things in the water as long as it's cool. But take the scenario. I don't live by a pool. I have to get dressed, get in my car, go down to the pool, walk in, go to the locker room, get my bathing suit on, get in the pool, do my workout, and then the reverse of that to get home. I might have just expended my energy for the entire day. And you have to look kind of at that risk-benefit ratio for that activity. But I'm not bad-mouthing aquatic therapy at all. The benefits are amazing. But you might want to investigate what you can do and what would be appropriate for you to do. And using an intermittent exercise strategy might be of particular benefit, particularly if you have a lot of fatigue. So, you saw that those Canadian guidelines said 30 minutes. Well, I can't do 30 minutes of aerobic activity. Then what? Well, you can break it up. The individual minutes count. So if you can do 2 minutes of something and then take a break, and then do another couple minutes of something and take a break, you're going to manage your energy levels better. You'll get the minutes in, and then ultimately you'll have those minutes in with less fatigue. And it's just so important for our overall health. Think about the things that kill us in America: heart attack, stroke. We just need to be more cardiovascularly fit. Everybody these days wearing Fitbit, step trackers. So I just mentioned them just because they're important to kind of track, to motivate you. And there was a research study to say that if you can improve your steps by 1,000 a day, you are making improvements on your quality of life, on your endurance, and on your overall mood. Well, what if you're not ambulatory? There are options. Arm bikes, buying a little arm bike you can sit on the table to get your arms working if they are able to do that, to get your heart rate up. In the clinic, we often have New Steps, which is a machine that couples arms and legs. If you're in a manual wheelchair and you want to put an odometer on there to see how much you're propelling. But even sitting and moving, whatever works on you to get your heart rate up, can be considered aerobic. And I had a really nice kind of introduction to balance from the previous speakers. And I just want to reiterate that it's really important to kind of pinpoint where the balance problems lies so that particular issue can be addressed. And that activities that you're working on for balance need to be done with control. They need to be challenging enough for you because you're trying to teach your body something new. But if the only thing that you're teaching your body is to grab onto something to catch your balance, then that's not teaching your body something that you wanted to learn. You want it to be in good control. So working with somebody who can kind of give you those ideas about what activities are appropriate is really the best. And here's the bottom line. The bottom line is to control the things that you can control. Many times people feel out of control with a diagnosis of MS. So there are things that you can do that will feel positive not only for your MS, but feel positive for your mind, body, spirit. Putting good food in your gas tank. You put bad gas in the Ferrari, it's never going to perform well. So garbage in, garbage out. Remember, exercise is you can think of it as a medicine, as a treatment. And a little bit is better than nothing. Quite often I hear people go, well, I'll start Monday, I'll do that next week. But just making small little changes to move yourself forward will be amazing. You can really start reaping the benefits of those. You want to make sure that you have some balance in your life. You want to have balance in work, rest, and play. No one thing is where you want to stay. If you are only working and it uses all of your energy and you have nothing left at the end of the day, then that's not a good balance. Having a good frame of mind, making sure you do your well visits. No lecture here, just saying it, stop smoking. Be an active participant in your medical plan and find things that you find that replenish you, that fill you up, that make you feel good, whether it's art or music or family time or reading a good book or just sitting and looking at nature. Feeling good about that whole body, mind, spirit is so essential. And so I thank you very much for your attention. Before we get our question and answer session, let's just recognize our last supporter.
The Consortium of Multiple Sclerosis Centers and Catamount Medical Education would like to thank Sanofi Genzyme for their generous support of this program. This support has made it possible for us to provide this valuable educational program for people living with MS and their care partners.
Well, welcome back, everybody. We have time for some questions and some answers here, and that's what we'd like to do. So I will take the questions that we have and we'll distribute them a little bit and make some comments as we go. There is a question here that is a whole lecture in itself. So the question is, how can MS affect you sexually? And what can I do to help overcome this? And I'd love to ship this off to one of my compadres here on the panel, but you know, years and years and years ago, I became kind of known as one of the sexual lecturers. It became concerning to me because I thought all of a sudden people were going to consider me the Dr. Ruth of multiple sclerosis. And Fred Foley, who is a psychologist in the New York area, is the true sexual expert in terms of lecturing about this. But I've learned a lot from him, and I've learned a lot over the years. Obviously, it affects you differently if you're a male or if you're a female. And as I said, this is a whole lecture on itself. In the male, the typical problem is that of erectile dysfunction, and there are many aspects to that are manageable with different types of treatments. We used to inject with a needle medication into the shaft of the penis, which would allow for a good workable erection. If you could inject your penis with a needle, we're having trouble enough getting people to inject their legs for MS with that needle. So then we had vacuum tubes we put on for a while that you'd pump up, and that would give you a good workable erection. But now, of course, there are pills that work, and they work quite well. In the female, the issue is usually a decreased sensation or decreased lubrication, sometimes pain. We call that dyspareunia. There are vibrators that are available that are very, very helpful and that are easy to obtain. They used to be difficult, but now you can get them through the mail quite easily. But a frozen bag of peas I've become known for over the years. And you take a frozen bag of peas and you can rub it in the vaginal area, and you can get a similar response to a vibrator. I know what you're thinking. You're thinking, what do I do with the bag of peas when I'm done? Actually, you can put them on your knee. You can put them back in the freezer and use them again, or you can eat them and get rid of all of the evidence. You know, the sexual response in a disease process, whether it's multiple sclerosis, whether it's arthritis or whatever, there's a lot of other issues that come into play. There's the medications that you take. There's your feelings and means of expression. The key to dealing with sexual difficulties, in my experience, is to be able to start communicating about them, to start talking about them. The person that you talk with as a physician or nurse practitioner may or may not be comfortable talking about it, but if you don't talk about it, you won't realize what's available for you. So the key there is to do that. Okay, I would like to pass on to Patty what is considered a high dose for biotin. I don't suspect you know the answer to that. I'd like you to also make a comment about what about ALA alpha lipoic acid supplement. But before you do, I will just sort of throw cold water on the whole issue of all these supplements and say, I don't believe in any of them. I've been around too long. I've seen too many. They come, they go, they're here today, they're gone tomorrow. But the key is to feel better. So if you feel better taking that supplement, what does it matter what I care about it? But the reality is most of them aren't worth the price that you're paying for. Patty, with that splashing of cold water, you can.
Yeah, no, you don't have to splash cold water. I'm of the same mindset. I mean, if we're really meant to get those vitamin minerals into our body, we can do that through our food. And some of these diets, or some of the diets I mentioned, or some of the diets that is kind of considered an American diet, we're really just very nutriently sparse. We're not getting our nutrients through our food. So, you know, there were several questions that came in about this, several different concoctions of vitamins, and they're touted to support the immune system or they're made for MS. And instead of commenting on them all, I would rather just say that if you're eating a well-balanced diet and you have had conversations with your physicians and your lab works are looking well, that you feel like you have good energy, then you're probably doing a really good job. If you feel that there needs to be supplementation, particularly, and I think you, everyone would agree, supplementing vitamin D would be beneficial if you're low in that area, you might meet with a nutritionist or a dietitian to look at how you can get full, whole foods in your diet rather than swallowing a bunch of pills. So that's where I stand on that.
Very good. Peter, who would know my EDSS? The PT or the neurologist, or where do you deal with what is EDSS anyway, Peter? Are you there?
I think you're muted.
Let's see here.
How about, do you hear me now?
Yeah, there you go.
Okay.
Go for it.
EDSS is a very structured neurologic exam that's very standardized. It gives you a score between 0 and 10, and it's a very reproducible score, and it's used as a parameter to measure disability. People that can do it could be your neurologist. At my center, the physician's assistants do it. As long as someone's trained to do it, then they can do it. Some people do a modified one, but there is a very formal structured scale, and it's a way to measure your disability, to monitor people's level of function.
So, Peter, I think you agree with me that EDSS means Expanded Disability Status Scale. It was started many years ago in the 1950s by a friend of all of ours who passed away a couple of years ago named John Kurtzky. And it's a way of measuring a disability in our patients from 0 to 10, where 0 is normal and 10 is dead from MS. And it's a complicated scale that involves a neurologic examination and asking questions. And so most neurologists don't know what the heck they're doing when they're doing it. And I can tell you that almost no physical therapists know anything about the EDSS. We do know that between 0 and 3, you walk pretty normally. But when you get to between 5 and 6, you can walk without an assistance device to requiring a cane to walk. And when you go from 6 to 7, you go from requiring a cane to walk to not being able to walk at all. And so it is something that we use to follow in studies, and we use it in our MS centers to follow disability, but it can be overwhelming. Wouldn't you agree to that?
I'd agree to that. I actually had the honor of training with Dr. Kurtzky, and the criticism of his scale always was that it was mobility scale. And it turns out he designed it when he was in the Navy studying MS patients, and he was studying their mobility. So anytime anybody criticized it for being a study of mobility, he smiled because they were criticizing him because it did exactly what he meant it to do.
Very good. Gary, do you know anything about MCT oil and scientific proven benefits for the brain?
MCT oil, no.
We're talking about cannabis.
Anything about MCT oil. I kind of agree with you that taking a lot of supplements probably doesn't help. In terms of biotin, we actually published a paper on that, and it showed it made some people with MS worse, and a recent phase 3 trial of biotin actually failed. So just another example of something with high expectations that didn't turn out to be as efficacious as one would have hoped. I'm not familiar with MCT oil.
I think they're probably talking about cannabis or some type of marijuana type of oil. The oils you can buy from various supplement places. Well, again, people take these oils. Sometimes they feel good with them. Sometimes they don't. It's up to the individual. But in terms of it changing the course of multiple sclerosis, I don't think any of us probably think that it does that. Clearly, the cannabinoids can change the symptomatic issues that occur with spasticity and with pain. We've seen that occur over the years. Patty, I don't know what a Lima strap is, but the question is there a new apparatus to take the place of a Lima strap?
Yeah, I'm not familiar with the Lima strap specifically, but the flick.
That's good. You're making me feel better.
Yeah. I'll look it up after this talk, but the hip flexion assist device, which most of our interventions happen, like when we're doing any orthotics or intervention, happen at the foot and ankle. And, sometimes the weakness doesn't lie there. It lies in the hip flexor muscles, the ones that actually bend your hip up for you to initiate that step. So there is something called a hip flexion assist device, which is a pelvic band. There's a band that goes around your waist and bungee cords, basically, that go down along each side of your legs and attach to your shoe. And they're tightened up so that as you go, even if you can initiate a little bit of that hip flexion to initiate a step, those kind of taunt bungee cords kind of help lift that up so that you can clear your foot. A lot of times people always think, well, I must need a brace in my foot if I'm dragging my foot, and that may not be the solution. That the problem may really be higher up at the hip, and the hip flexion assist device is one that can address that.
Very good. Peter, I think this is probably aimed for you by the way it's written. Is talk specifically about the most up-to-date information about what you can do about our eyes and stopping the progression of the disease. The person says, it's my right eye too.
It depends on whether it's an acute eye symptom. So if you're having an acute attack of optic neuritis, then you can treat that and ease those symptoms with steroids. If you're having double vision or something along those lines, there's another exacerbation, then that's just something you manage as an exacerbation like all others. If you're having just progressive visual loss over time, that tends not to be MS related. And I always tell patients, you can think of your eyeball as the camera and your brain as the processing of the film. And so you need to decide whether your vision is a camera problem or a processing problem. Progressive visual loss in MS tends to not be a common symptom that I see.
Patty, does it make any difference that I drink only carbonated water?
I don't think so. The carbonation, doesn't add any, calories or sugar or anything to it. I would much rather have you drink carbonated water than not drink water at all. So I don't think that that's really a factor.
Very good. I'll take this one. I joined late. What would be the urologist's role toward my care, and should I change the one I have? And I don't know that joining late would affect the answer to this, but it's an interesting question because everybody, as Peter said on his team, I think there was a urologist, and urologists hate MS. I'm just going to tell you that right up front. Urologists hate MS, and most of them do a terrible job in dealing with MS. And the reason they hate MS and the reason they do a terrible job in dealing with MS is that urologists are surgeons. They're surgeons. They're trained in surgery. They love to fix things. If you have a prostate problem, they love it. I can vouch for that. They fix me up pretty darn well. They're surgeons. If you have a fallen bladder, they sew it right up and it gets fixed up, and they do really well with that. But most urologists don't know how to talk. And so when you have a problem with your bladder and you're trying to tell them what to do, they're not the least bit interested. They'll try a little bit of this, but not all of them. If you find a good neurourologist that actually will talk and will actually be able to work with you, they're golden. But why do we want a urologist on our team then if they're so if they don't really do well with MS? It's because they can do the testing. They can look at your bladder and they can do urodynamic studies that tell us very objectively, is this a small bladder? Is this a big bladder? Is this a conflicting bladder? Is this a this or that or the other bladder? Or is it not a bladder? Maybe it's the prostate. Maybe it's a fallen bladder. Maybe it's something mechanical. So that's where our urologists come into play. And so it is my hope typically that the neurologist should be able to figure out and help you with your bladder and deal with it. So if they can't, we try to find the right practitioner that can. So it all depends on your own circumstances. I got another one here for you, Patty, that I could answer too because I live there too, but could the living in high altitude with low oxygen pressure change the prognosis of multiple sclerosis or the incidence of it? And I'm throwing this to Patty because she lives in the mountains of Colorado, and I used to live there too. So
right, my compatriot. Altitude and oxygen should not have any impact on the disease itself. Now, I can tell you from personal experience that when I first moved out here, that my endurance and my fatigue levels were much higher because I was at altitude and I just didn't have the level of fitness to be able to, manage that lower oxygen levels. But I'm not aware of anything that if you live in a mountainous area in higher altitude that would have any impact on the disease itself.
No, I think you're absolutely right there. Gary, should we be concerned about taking our medication during COVID-19?
There are certain disease-modifying therapies that can certainly affect immune function. The immune system in COVID-19 is a double-edged sword, as we're now learning. You can have an over-response of the immune system in people infected with the coronavirus, and that can actually cause what's called a cytokine storm, and they're now using an anti-IL-6 antibody to actually modulate that. There were some recent observations that triple antiviral therapy, including interferon beta, may have an effect on the course of COVID-19. This was not a randomized gold standard clinical trial, but there could be medications that have the potential to be beneficial. Certainly, if you're very immune suppressed, and certainly some of the disease-modifying therapies would do this, potentially you could be more susceptible to the development of the disease. It turns out it's very complicated. It's not just whether you're exposed, but also the dosage of the exposure that may be very important as to whether you have a mild or a severe case of the disease. So if I were on a disease-modifying therapy with major immune suppression, I would be especially cautious, hand washing, social distancing, wearing a face mask, all of the usual factors. I'd like to say a word about a urologist, if I may. There is a treatment which I found very useful, which is intravesicular Botox. And I don't know if you had any experience with that, but I have really found that to be very effective, administered by a urologist in the treatment of uncontrollable spastic bladder.
Again, that's a procedural thing. I have had a lot of experience with that, actually. And you're very right. It can be very effective if you have a spastic bladder that's small and wants to be stimulated all of the time. We're running out of time. There was a question about hyperbaric oxygen that disappeared. I thought I'd just answer that real quickly because I did a study with hyperbaric oxygen, and it's of no value in MS. It's been studied in a randomized, double-blind, placebo-controlled fashion, and it is of no value in multiple sclerosis. We could just say that point blank. I'm just looking here. Has marijuana been used in studies to help improve MS symptoms? I think we talked about that. It can be used for MS symptoms, including spasticity and pain. It's an interesting entity because it has immunologic effects as well, but those haven't been studied as well. So that needs to be studied. I'll just take a couple last one here. Patty, is there any food typing affecting the trigger or prognosis of multiple sclerosis? I'm glad I'm not answering that.
So I think that there is some literature out there about food typing according to your blood type. And I think that that's where that question may or may not be coming from. But right now there is no evidence or no work to my knowledge about particular food groups or typing food groups for MS. I think that has to do more with how is our food, how is our nutrition impacting different cellular components of our body, and how does that impact someone living with MS?
Well, we still have questions to answer, but we don't have time to answer them. So I'm going to just thank you all for participating in this. We tried to get as many in as we possibly could. I've thoroughly enjoyed being involved in this seminar. My faculty, I think, are wonderful. I appreciate you hanging in there and listening to us. And I'm going to conclude by saying I wish you all well. We've got a lot of issues that we're all dealing with these days beyond multiple sclerosis, and my thoughts and prayers are with you all, and I know all of our faculty feel the same for all of you. And at this time, I'm going to turn this over to the folks to present the word game results. I will present them, but I have to see them to present them. So look at this, guys. This is what happened with our word gaming. And so now you look at this and you see, describe one word to describe your model for living with MS. And what you see standing really out at you is survivor, journey, challenging, perseverance, strength. But look at the other ones. They're all so good. I think this is really something very important for us all to study. Hopeful, unbreakable, positive, courage. I think that this would go on the wall of any MS center clinic and be an inspiration for all of us. Do any of you on the faculty have any comments further about this in particular? Please feel free to speak up.
No, I think it's wonderful.
All right. So now we'll conclude with information on how to receive the post-program materials and how to download or view the virtual exhibition hall. And I thank you all.
Thank you, Dr. Shapiro, and all of the faculty for such an amazing and extremely informative program. Where this is just a small reminder to please visit our exhibit hall. Just to visit our exhibit hall. Again, you will be able to access information provided by the exhibitors for people living with MS. And also at the, all the participants, all the patients who have participated in this program will receive post-program materials in the mail in the next few weeks. If you didn't provide your postal address, please visit capmedeD.com/MS patient to submit your information. Thank you again for joining us and have a wonderful rest of your day.